Welcome to Windsong's Health Conference. We thank you for joining us for healthcare trends for 2020 and beyond. Please understand that in order to receive credit for this conference, you must complete the post-test with a minimum score of 70. Links to the post-test and evaluation were sent along with your registration. And now it is my pleasure to introduce our first speaker, Dr. Safet Likparik.
So again, my name is Dr. Safet Likparik. I work with Dr. Dana Dunleavy. He's the Director of Interventional Radiology here at Windsong Radiology. Here you can see our staff of IR techs, nurses, PAs. So I think of interventional radiology kind of like surgery, but it's only magic, i.e. we don't really use scalpels or anything to cut anybody open. We use wires, catheters, and needles to treat patients in a very minimally invasive way. So in addition, we've added Dr. Arush Sheikh, who's also an interventional radiologist with us. And in addition, we work closely with our mid-levels, Linda and Liz, and they help us very much in the clinic. So I like to compare interventional radiologists to MacGyver. I don't know if anyone knows who he is, but he was a famous protagonist in a TV series played by Richard Dean Anderson. Like IRs, he really likes to use non-lethal resolution to conflicts. He'd never carry a gun. He'd always carry a Swiss Army knife. And similarly, we never, us IRs don't really carry scalpels or anything to cut anybody open. We essentially just use small needles, wires, and catheters in a very inventive way to treat patients. And well, how do we do our job? Well, we use image guidance. And so here at Spindrift Drive, we have a state-of-the-art GE angio suite, which for the most part is only found in major tertiary care center hospitals. But we have it here and we use it, and this is the workhorse for our procedures. This is an example of using our angio suite for a patient who during COVID had a liver cancer, who couldn't really or preferred not going to the hospital, came here, and we performed a Y90 radioembolization where we went into the hepatic arteries and treated the patient with radiation successfully, and the patient went home without any exposure to COVID. This is another example of a female patient who presented to us for uterine artery embolization and had a CTA before the procedure. Notice here how what we did, we used the CTA and we overlaid it to the patient to reduce dose during the procedure and to reduce contrast. This is an example here of a prostate gland enhancing with contrast in the angio suite. So during the patient's prostate artery embolization, we confirmed that our microcatheter was in the prostate artery as it enhanced nothing but the prostate. Outside of using our angio suite, we use ultrasound. Ultrasound requires no radiation. In addition, we actually have a specific type of ultrasound known as fusion technology, PercuNav from Philips. It's a technology where we can pull an MRI or a CT from a prior imaging study and fuse that into the actual patient and scan the patient with ultrasound and find the lesion with ultrasound using our MR or prior CT. And we use this for biopsies or ablations. In addition to X-ray and ultrasound, we also use CT scan. So here I am performing a cryoablation of a patient that has a renal tumor. And here we're freezing the patient's tumor. Patient goes home same day under CT guidance. Just a little, just wanted to touch base on radiation carcinogenesis. I know this is something that people are concerned about. So I just wanted to give a background to the story. Notice that for the most part, any American walking has a 40% chance of getting cancer, and that's lifelong. Cancer incidence with radiation is 1% per 100 millisieverts. Keep in mind here at Spindrift, not most, but all of our procedures are way less than 100 millisieverts. The highest millisieverts that we can attain potentially would be close to 50. Again, comparing that to a CT scan, that's around 10 to 20 millisieverts. So there is no data to prove any carcinogenesis related to a dose less than 100 millisieverts. Now, above all, outside of being proceduralists, we're clinicians. And so before we do any major invasive procedure or minimally invasive procedure, we're going to perform a full clinical evaluation. Now this is our first case presentation. This is a patient, a 63-year-old female, male carrier, presents with a 5-year history of bilateral leg varicose veins, achiness, episodic swelling, heaviness, itching worse after a long day of work. She has worn compression stockings on and off over the past year with improvement of symptoms. She denies claudication or shortness of breath. Physical exam shows bilateral leg swelling with prominent varicosities. She went on to get imaging, which showed reflux of the bilateral great saphenous and small saphenous veins. This is a patient that presents with classic chronic venous insufficiency. Chronic venous insufficiency is a disease of venous hypertension in the lower extremities. It is surprisingly very common, 2 times more common than coronary artery disease. The etiology varies. It can either be primary, i.e. just the valves of the superficial veins are not working and there needs to be a couple to not work for this disease to present itself, or there could be an underlying deep venous obstruction, such as a patient that had a prior DVT that has some degree of post-thrombotic syndrome. Now, what do you notice? What is one major presentation of this disease? Well, varices. What are varices? Varices essentially are veins that have systemic weaknesses to it due to the venous hypertension. And the veins that present are usually the great and small saphenous veins, as well as their tributaries. This is a couple of pictures of what you'd see in venous disease. Here you notice varicosities, and then as the disease progresses, you notice swelling asymmetric, left greater than right, and then the patient may go on to have pigmentation. And unfortunately, many patients, a certain percentage of patients develop venous ulcers, particularly on the medial malleolus. Now, what are the clinical features of chronic venous insufficiency? Well, like we mentioned, you're going to have limb pain, swelling. Now, the swelling usually is episodic, usually at the ankles. It's not as prevalent, but for the most part, you'll have skin changes, varicosities. Patient will also complain of itchiness, restless legs, nighttime leg cramps, and episodic ankle edema. Now, between vascular specialists, in order to talk the same language, we use something called a CEEP system and a VCSS score, just so everyone understands what degree of severity the disease presents with. Now, how is this treated? Well, conservative treatment is the initial treatment of choice to treat. Unfortunately, compression stockings is the treatment of choice for conservative management, and it has a lot of pitfalls. Application difficulty is probably number one due to obesity, fragile skin, patients with arthritis, also contraindication for patients that have peripheral arterial disease. And for the most part, non-compliance is a major cause of compression failure. Now, so after the patient has tried a 3-month compression trial, the subsequent treatment, treatment of choice, in my opinion, and to the opinion of the specialist, is minimally invasive corrective procedures. Now, routine stripping of the saphenous vein, which is a surgical procedure, a procedure that has comorbidity, was the treatment of choice years ago, but more recently it's been replaced by radiofrequency ablation and laser treatment. Laser treatment and radiofrequency ablation is a percutaneous minimally invasive treatment that has 84 to 94% success rate, and even higher with more up-to-date data. This is an example of radiofrequency ablation. Here you can see the probe is within the varicose vein, or the great saphenous vein, and we introduce this catheter through a pinhole size in the skin, enter into the vein, and then we'll numb around the vein, and then we'll start the ablation, which generally lasts the entire procedure less than 15 minutes or so. So outside of radiofrequency ablation, there is an option which is non-thermal, non-tumescent, so it doesn't require any more than one poke in the skin. And the common product that we use here at Windsong is VenaSeal, and it's approved by many insurance carriers, and the amount of insurance carriers are growing in terms of approval. And it also has very similar efficacy. In addition, it has less pain, faster recovery, and no requirement for compression stockings after treatment. Going back to our case, that patient underwent bilateral great saphenous vein and small saphenous vein VenaSeal treatment, followed by microthrombectomy of the anterior calf, So notice here on the right, the anterior calf varicosities have completely resolved and the swelling has significantly reduced. And on the left leg, notice how the medial thigh varicosity is no longer present and the actual swelling has reduced. This is just a corollary of a patient that underwent microphlebectomy. Here you notice the varicosity along the anterior thigh, and after removal of the varicosity, you notice this is the actual vein being stripped away. Post-treatment thigh looks remarkable, looks beautiful. No varicosity present. This is an example of sclerotherapy. So after we have the patient undergo ablation, occasionally there will be some telangiectasias, as you notice here, that have yet to resolve, and we can touch that up with some injection sclerotherapy, and notice the before and after pictures are incredible. So next case presentation, we have a patient, a 49-year-old female, CEP5. So CEP5 means the patient had an ulcer and it's healed. Now this patient presented with a 10-year history of chronic venous insufficiency, status post multiple bilateral superficial venous ablations and several microphlebectomies. Family history of varicose veins. Patient currently has bilateral leg swelling, left greater than right. So the patient went on to have duplex, and we evaluated the deep venous system. No evidence of DVT, but there was deep venous reflux within the bilateral venous femoral veins. So, concerned with some deep venous disease, we went on to a CT venography that showed a compression of the left common iliac vein by the right common iliac artery. Now this presentation with recurrent varices with left greater than right swelling is very consistent with what's called May-Thurner syndrome, also known as Cockett syndrome or iliac vein compression syndrome. Now, it's been postulated that right common iliac artery overlying, so here on this image here, I'll show you with my mouse, this is the right common iliac artery lying over what is the left common iliac vein. Notice how the left common iliac vein is being compressed by the right common iliac artery over the vertebral body. So this compression has been postulated that the pulsation of that right common iliac artery is creating an inflammatory reaction. And unfortunately for many patients, it also leads to an iliac flow obstruction. And so as a result, flow must go in a different direction. With this constant pulsation, it predisposes patients to DVT. When you include additional triggers, such as patients being on contraceptives, pregnancy, inherited thrombophilias, trauma, and surgery, you predispose patients to DVT. Now, treatment of iliac vein obstruction, well, how do we treat it? More recently, a lot of data has shown venous stenting to work, to reduce swelling by 58%, to reduce pain in 79% of patients. So there is significant data to show this works, and this is what is being done in a minimally invasive way. To give you an example, to go back to our patient, we went ahead and underwent a venography, pelvic venography, where we went into the left common femoral vein and injected contrast. And that contrast should go up the left common iliac vein and go into the IVC. But here you notice the contrast going up the left common iliac vein, stopping, coming to a complete halt, and going downward. It's not supposed to be going downward. This downward flow is going into the pelvis, it's going into collaterals, going into the internal iliac, and then coming and making its way to the other side. It is using alternative routes. This is obviously not good for the patient. This is what's causing the patient's symptoms. So we went ahead and placed a venous stent. Here you can see the venous stent. And then we injected contrast from that left common femoral vein, and notice the flow is beautifully going up into the IVC with no issues at all. So to conclude, just to give you a synopsis, here you can actually see the flow nicely going up to the IVC. And just for comparison, look at the flow going from the right common iliac vein to the IVC. And the pre-pictures, look at how the flow from the left is not making its way up to the IVC, it's going down. In addition, we use IVUS, and just to quickly touch base on what that is, it's ultrasound inside the vein, and we use that to confirm exactly where the stent will go. We're one of few places in the United States to use IVUS. It is not common, unfortunately. It is something that we do, and it has improved our precision exponentially. and everyone else's, of course. This is a case companion. Notice how, so this is another patient that has May-Thurner compression. Notice how when the venography is performed from the left common iliac vein, you can notice contrast going up and also coming to a complete halt here, and making its way through pelvic collaterals, pelvic cross-filling collaterals, to make its way along the right side. This will lead to pelvic venous hypertension. And so in addition to that left greater than right swelling, patients can also complain of pelvic pain. This is an actual fluoroscopy save video of that flow. Look at how the flow comes to a halt, makes its way across through these channels to the right side. Next case, we have a patient, 35-year-old female with a chief complaint of varicose veins. She described bilateral leg aching and heaviness, worse at the end of the day. She has a past medical history of leg varicose veins. On additional review systems, we identified painful vulvar varices, especially following intercourse, as well as pelvic heaviness. Physical exam demonstrated bilateral anterior high thigh vulvar varices. We went ahead and underwent bilateral leg duplex, which showed anterior thigh varices and bilateral great saphenous vein reflux. In addition, we went on to perform a pelvic ultrasound because we were concerned that these varicoses may be related to the pelvis, which indeed they seem to be, as we identified bilateral adnexal varices. So, in addition to the May-Thurner compressing that left common iliac vein, leading to reflux in the pelvis, there's a whole gamut of venous disorders that can lead to pelvic venous hypertension. We'll go through that now. One being ovarian internal iliac vein reflux, also known as pelvic congestion syndrome. This is where, if you look at the slide, the image to your right, notice how that left renal vein, off of the left renal vein comes a branch vessel, and that's the left ovarian vein. This left ovarian vein usually brings blood flow from that left ovary up into that left renal vein and into the IVC. In this process, in this disease process, multiple valves along its path malfunction for an idiopathic reason. And as a result, instead of blood going up as it's supposed to, it goes down into that pelvis, leading to the congestion. So that can happen on the right ovarian vein as well. And it can also potentially happen in the internal iliac veins also. Now, in addition to ovarian vein reflux, pelvic congestion syndrome, another etiology is what's called left renal vein outflow obstruction, also known as nutcracker syndrome. And in that etiology, what happens is usually the left renal vein makes its way into, the blood makes its way from the left renal vein into the IVC. But because of a compression, usually by the superior mesenteric artery, which lies over that left renal vein, because of that excessive compression that can happen in certain patients, blood does not make its way, and so it has to make its way through collateral. So it makes its way through that left ovarian vein and through other collaterals such as iliolumbars. And that, unfortunately, can lead to pelvic venous hypertension. Now, another etiology, as we mentioned, is May-Thurner compression, and we briefly discussed that as well. How do these patients present? Well, as we discussed, they present with varicosities that are refractory to ablation. They can also present with left flank pain and hematuria, primarily in the setting of nutcracker syndrome, or they can present with chronic pelvic pain, which is typically seen in pelvic congestion syndrome. Now, of course, how do you treat these patients? Well, it is an individual approach. When I started here at Windsong, it was a maze, and Dr. Dunleavy, with his expertise, was able to identify and educate me on the various ways of treatment. And since then, the level of expertise has grown exponentially, and so it is a tailored approach. Here is an example of a pelvic ultrasound. Here you can see bilateral adnexal varices, and this is usually the screening tool that we start with to at least show pelvic varices and adnexal varices. Occasionally, we'll subsequently move on to MRI because of the dose reduction and the non-radiation. Here you can notice we can occasionally move on to CT venography in patients that are claustrophobic or for other various reasons. Here you notice the enhancement of the varices, which is obviously abnormal. Here are the arrows showing left greater than right adnexal varices. Now again, just to reiterate, May-Thurner syndrome, compression of that left common iliac vein, leading to that obstruction and the reflux of flow going into the pelvis. And notice how this could easily cause pelvic venous hypertension. Here is a picture of the nutcracker. Again, we briefly went over that. Notice how this is in a real venographic image. Notice how flow, the black here is contrast. Notice how this contrast is not making its way to the catheter. The catheter here is in the IVC. Usually you will see the dark contrast making its way across to the catheter into the IVC, but it's not. It's obviously going down where it's not supposed to in the pelvis and making its way up another collateral, which is the iliolumbar. And this is an example of pelvic congestion syndrome. And to differentiate this from May-Thurner, you notice that flow is making its way across that left renal vein, but it's also making its way down. And that's because of the reflux of the left ovarian vein. And in an additional subsequent image, you can see that contrast making its way into the pelvis, creating that pelvic venous insufficiency, leading to the pelvic venous hypertension and creating the syndrome of pelvic venous congestion. Now, to speak about the syndrome, as we mentioned, it's a chronic condition associated with non-cyclic pelvic pain affecting women of reproductive age. Pain is worse in the upright position and relieved with supine. It's worse with pregnancy, and as we mentioned, we confirmed that with pelvic ultrasound and MR venography, and the gold standard is venography. Venography is not only diagnostic, but also therapeutic with embolization. A couple pictures showing some diagrams of the left renal vein and the left ovarian vein and the right ovarian vein, leading to significant congestion around the uterus and around the ovaries, creating what is known as pelvic venous hypertension. Here's a CT coronal demonstrating a significant amount of pelvic varices and parauterine veins that are dilated. Here's a laparoscopic view of that. Here you notice, here's a venographic view of what we saw. How do you treat this? Well, PCS is treated with minimally invasive treatment options. 3 systemic reviews have shown efficacy. The only concern is that the data is poor and more data needs to be gathered. And so in our retrospective review, in our significant volume of cases here at Windsong, we've demonstrated significant improvement in patients, particularly going back to our case presentation. Our patient went on to undergo a left ovarian vein embolization. Here notice the left ovarian vein post-embolization with plugs. Now you notice that there's no more left ovarian vein reflux. In addition, the patient went on to complete symptomatic improvement. Just to compare, here's a view of the pelvis on sagittal. Here you notice the IVC dividing into the internal and external iliac veins and the pelvic branches. Now, just to reiterate, the ovarian vein refluxes into the pelvis, and usually the pelvic veins will hold the blood flow. But for this particular patient that we discussed, you can have what are called escape points. These are points where blood will go from the pelvis into the legs, i.e. through pudendal branches, gluteal branches, obturator branches, or inguinal branches. And that's what can lead to the associated recurrent varicosities in patients with pelvic venous hypertension. This is a particular patient that we treated recently who said, in her opinion, she was very happy after the procedure. She is thankfully 99% pain-free after undergoing pelvic vein embolization. Here's an example of her venography. Here you notice the left renal vein wildly patent, and there's significant reflux going down where it's not supposed to, into the pelvis. Post-embolization with plugs, here you see 2 plugs. Notice how there is no flow past the plugs, consistent with the patient's symptomatic improvement. Next case presentation. So we have a 40-year-old African-American woman with a history of progressive menorrhagia, severe dysmenorrhea. She had previously tried oral contraceptives with only minimal improvement. She also expresses abdominal distension and increased urinary frequency. Unremarkable past medical, past surgical history. Physical exam shows a 12 size 12-week size uterus. Pelvic ultrasound and MRI demonstrates a uterine fibroid uterus. Now, fibroids. Fibroids are the most common benign tumor in women. They're common in women of reproductive age. Unfortunately, they affect black women in a more statistically affected way. They have more pain in general. Unfortunately, so in general, the economic burden of fibroids is estimated to be between $5 to $34 billion. How do they present? Well, similarly to our case presentation, they'll present with menorrhagia, anemia, and reason being, it really is all dependent on where the fibroid's located. So if you have a fibroid that's compressing, the intramural is endometrial, submucosal, and compressing the endometrial lining, you're going to lead to bleeding, obviously, and the patient may also suffer from preterm delivery and infertility issues. If the fibroid is large and is compressing the rectum, you'll have difficulty with constipation. So here is a sagittal view. Here, this is the uterus. Posteriorly, you have the rectum. Anteriorly, you have the bladder. So if the fibroid is compressing anteriorly, you'll have compression of that bladder, leading to urinary frequency. If the fibroid is compressing posteriorly in the back, again, you'll have degrees of constipation. So if the fibroid is very large, it can lead to bloating, compressing, and protruding into the abdomen. What are the treatment options for symptomatic fibroids? Obviously, the patients that are asymptomatic require no treatment. The treatment option that was previously standard for patients that have completed childbearing is hysterectomy. The major concern with hysterectomy is the adverse events, and they're common. 28% of patients with hysterectomy undergo major blood loss, wound complications. So, many uterine-sparing options have been developed. Medications have limited efficacy. Endometrial ablation is limited to patients with complete childbearing and only patients that have menstrual bleeding as their major symptom. Myomectomy has been the traditional option for uterine sparing. You have open, laparoscopic, and hysteroscopic. Concern for hysteroscopic is that if patients have very large fibroids, it may not be feasible. An additional option that we're going to delve into today is what's called uterine artery embolization. It's a minimally invasive option that does not require surgery. It requires a mere pinprick in the wrist or in the groin. Here at Windsong Radiology, we have a radial first approach where we prefer to treat patients through the wrist because they get to go home within 1 to 2 hours after the procedure. And so in order to do that, we'll access the left wrist, left radial artery, bring a catheter down into the left and right uterine artery. Once we're in that left uterine artery, here you notice we inject contrast and we can see the enhancement of the ball-like fibroid. And at that point, we're ready to treat with embolic agents. So what we'll do is we'll go ahead and inject embolic agents to close that blood supply to the uterus. And as a result, the uterus will shrink in size, the fibroids primarily will shrink in size, and the symptoms will, for the most part, resolve in 1 to 2 months. Evidence, there is significant amount of evidence to support this procedure, years, decades worth of evidence. And so more recently, the ACOG in 2008 had determined uterine artery embolization to be level A in terms of a uterine sparing option. As of a couple of months ago, there was a head-to-head open label randomized multicenter trial comparing uterine artery embolization to myomectomy, and this was studied in the New England Journal of Medicine, which showed significant improvement in quality of life in both the myomectomy and the uterine artery embolization arms from 42 to 80, from 37 to 84. In addition, we had significant improvement, obviously, in quality of life. When you compare the two, you notice the complications were not statistically different, but there were 50 overall complications in the myomectomy group and 29 in the uterine artery embolization group. So lower, but not statistically significant. Both arms were able to have pregnancy after. I know that was a concern in the past, but 9 women in the uterine artery embolization group, 8% were able to undergo pregnancy, while 4% in the myomectomy group were able to undergo pregnancy successfully. And again, to reiterate, uterine artery embolization, the median length of hospital stay was less. In general, at Windsong Radiology, patients go home the same day, versus in a myomectomy, patients generally stay 2 to 3 days. To conclude with our case, our patient underwent uterine artery embolization successfully. In the first month, usually patients will describe some recurrent symptoms, but usually 2 to 3 months after, for the most part, they have marked improvement of symptoms. And this is our patient had significant resolution of symptoms. This is an example of bilateral internal iliac artery angiograms demonstrating the tortuous uterine arteries. This is the right uterine artery. This is the left uterine artery. We will go into these uterine arteries with a microcatheter, inject beads, and close off the blood supply. Surprisingly, it does not lead to any issues with the uterus. It just essentially shrinks the fibroids. 6 months after the patient underwent an MRI, this is the pre-MRI sagittal view. Notice the large fibroid. 6 months after our procedure, it's gone down to a peanut size. So this is inconsistent with the patient's symptomatic improvement. Next patient, we have a male patient, 65-year-old male with a history of incomplete emptying, increased urinary frequency, intermittency, urgency, weak stream, and nocturia. He has a past medical history significant for a long history of benign prostatic hypertrophy, refractory to medical management. His PSA is elevated, but not remarkably elevated, and it's been stable over the past year. We went on to perform a pelvic ultrasound, which showed a very large prostate, 173 grams, with findings of obstructive urinary retention. An MRI of the prostate showed no evidence of malignancy. Now, this patient has benign prostatic hypertrophy. Now, what is that? Well, similarly to fibroids, it's a non-cancer enlargement of the prostate gland that happens. It happens with aging. More than 50 to 75% of patients over the age of 50 have this. Over 80% of men over the age of 70. What are the symptoms? Well, the symptoms, as we described, you can consider them in 3 buckets, all of which are under the classification of lower urinary tract symptoms, LUTS. So you can have storage symptoms, the issues with frequency, having to go to the bathroom frequently, urgently, having to wake up in the middle of the night to use the restroom multiple times, and not being able to hold your urine. You can have voiding issues, weak stream. Dribbling is one of the major issues that many of my patients and Dr. Dunleavy's patients complain of. Patients can also complain of post-void, a sensation that they have to go but they can't. And that's primarily due to the fact that they have urine in the bladder that's unable to be released because of this obstruction. Now, well, what can you get with BPH outside of these unfortunate and irritating symptoms that affect your lifestyle? Well, you can have complications. Urinary tract infections can arise. You can have a bladder outlet obstruction that requires a Foley catheter placement. You'd have to walk around with, unfortunately, a suprapubic catheter. Bladder stones can happen because of the stasis of the actual urine in the bladder. And over time, this leads to renal insufficiency. What are the treatment options? Well, the number one treatment option is lifestyle, of course, trying your best to avoid drinking excessively before bed, scheduling your voids. Now, this obviously, as you know, is not ideal for patients. Medical therapy is the next option, and it has its downfalls in terms of side effects. Surgical intervention and endovascular therapy are other options. Now, these are a list of medical options that are available. Now, they do have benefits and they do have side effects. Side effects include, but not limited to, sexual side effects, as well as blood pressure, low blood pressure, and syncope and dizziness. Surgical options. Now, in order to have a patient be considered or a candidate for surgical therapy, they must have failed medical therapy or just not want it. The options include prostatectomy, which is a very invasive procedure where the prostate is removed. And this is generally limited to patients that are not candidates for TURP. TURP is a minimally invasive procedure offered by urologists where they will shave portions of the prostate through the urethra. And so this is a standard care option that's offered by urologists. In addition, urologists will offer what's called laser vaporization and UroLift. Now, I'm going to delve into a different option that we offer, which is known as prostate artery embolization. But before I do that, let me briefly mention some common complications that are seen in patients' status post-TURP, and they include bleeding, infection, urethral strictures, postoperative pain, urinary tract infections, and erectile dysfunction. Now, going back to what we were just discussing, prostate artery embolization is similar to uterine artery embolization, where we, through a pinprick in the wrist or the groin, will go into the right and left prostate artery and inject embolic agents to close off the blood supply. Surprisingly, there is no long-term damage to the prostate. The prostate gland functions normally, but fortunately for the patients that undergo this procedure, the prostate gland shrinks in size, allowing for improvement of symptoms. As of June 2017, PAE, prostate artery embolization for benign prostatic hypertrophy, was approved by the FDA. Again, just to reiterate, in order to undergo this treatment, we will perform contrast injections into the arteries, showcasing the prostate artery, and using a microcatheter similar to uterine artery embolization, we'll advance our microcatheter into the prostate artery and inject our embolic agent. Here's an example of enhancement of the prostate artery, and notice how there's a significant amount of branches in this area. So as interventional radiologists, we specialize in the anatomy, so we are diagnostic radiologists as background, so we have to identify the complex variant anatomy intraprocedurally and make sure that we are treating the right vessels. Thankfully, we have what's called cone beam CT, where we're able to inject contrast, perform a CT scan in the angio suite, and confirm that we're injecting into the prostate gland and not anything else. And this helps to minimize side effects. In addition, we have software known as automated vessel detection software, where we, in addition to our diagnostic skills, we can use software to help us identify the prostate arteries. Now, PAE is safe and effective. Multiple studies have shown experience very effective long-term data. This is a recent study that shows a 10-year experience with PAE, showing significant improvement comparative to TURP. This is another study, which is an open-label randomized trial comparing PAE and TURP. This is a non-inferiority study, which conclusion demonstrated reduction of lower urinary tract symptoms in PAE, similar to TURP in a 12-month follow-up, with fewer complications. In addition, when you compare PAE to the standard option of TURP, when you compare the cost analysis, you'll notice that the cost analysis, it's actually, from a healthcare standpoint, costly, slightly more costly to undergo TURP versus PAE. Now, as an evidence summary statement, PAE is indeed non-inferior to TURP when it comes to improvement of lower urinary tract symptoms. It's safe with fewer major complications in the range of 0.2 to 0.6%. And most importantly for many men, it preserves sexual function, not having that risk of erectile dysfunction. Going back to our case, now this is a patient, Greg, who was very vocal with us and told us, hey, you are able to tell the world about me because I feel great. He was unable to walk the beach with his wife before the procedure without having to use the restroom every 45 to an hour. Fortunately for him, he underwent prostate artery embolization, and 6 months later, his prostate gland decreased in size from 173 grams to 96, a 45% reduction in his size of his prostate with significant improvement in his symptoms. He's able to walk the beach now with no complaints for 2 to 3 to 4 hours. Here you see on the right just an example of a microcatheter injected into the right prostate artery and a microcatheter injected into the left prostate artery. We do a CT scan, contrast enhanced, injecting through these arteries, showing a yin-yang enhancement of the prostate gland. Here is the half semicircle prostate gland enhancing, and here's the left, nothing else enhancing. And this is consistent with proper location of where we want our microcatheters to be, injected the embolic with great success 6 months later. Now, next case presentation, this is going to be our final case presentation. This is our 85-year-old female, Caucasian female with a history of osteoporosis, presents to her PCP with complaints of back pain after a recent fall. Patient was placed on medical management and braced, yet she continued to have intractable pain. Her visual analog score revealed a 10 out of 10 pain with severe limitations in performance of activities of daily life. She went on to perform imaging which showed compression fractures in multiple levels of the thoracic spine. Now, osteoporotic compression fractures are very common. They're actually the most common sequela of osteoporosis. In order to diagnose, you undergo imaging, preferably screening option with lumbar and thoracic radiographs. MRI will help to differentiate subacute, acute to chronic fractures. These patients should undergo DEXA scan. Conservative management is usually the management of choice, but treatment options for failed conservative management do exist. And so what's very important to know for these patients is that in order to treat these patients, they need to be treated to prevent fractures. Okay, so the National Osteoporosis Foundation has made a synopsis of major recommendations for clinicians treating patients with osteoporosis, and here is a list of things that are very important to make sure the patient has in hand prior to doing any minimally invasive treatment. Now, what are the treatment options for osteoporotic compression fractures? Well, vertebroplasty, where we inject cement and create a cavity, inject cement into that compression fracture. Implanting an actual device to restore the height is another option. Surgical fusion is a open surgery option. And kyphoplasty, where we insert a balloon, expand that cavity, and then subsequently inject cement. These are all treatment options. Comparing the minimally invasive treatment options, i.e. vertebral augmentation, to the conservative management of non-surgical management, you notice there's a significant improvement in pain and quality of life and overall lower rates of subsequent vertebral compression fractures. So you wonder why conservative therapy is offered. So meta-analysis of 5 studies show that there's very low quality for this initial option of conservative therapy. When you compare it to vertebroplasty, you notice there was a study done comparing 10-year sample of U.S. medical data, comparing vertebral augmentation to conservative therapy, i.e. bracing and physical therapy with medical management. And you notice that there was a number needed to treat of 11.9 in the kyphoplasty group and 23.8 in the vertebral augmentation group, meaning when you compare the two, you are saving 11.9 patients, saving their lives for every kyphoplasty that you do. Going back to our case presentation, our patient was subsequently treated by Dr. Dunleavy with vertebral augmentation of the T2 through T5 levels under fluoroscopic guidance. The patient went on to have significant improvement of her symptoms with only 2 out of 10 pain. She was able to ambulate fine without assistance, returning to baseline status. This is just some example of height implantation using spine jack. Here you can see the compression fracture, and here you can see our spine jack implantation. Notice how there's significant restoration of height. We also offer this for particular patients given the scenario. Now, just want to briefly mention that in addition to the procedures that we went over and the disease process that we discussed, interventional radiologists also treat cancer. And before we treat cancer, we help the oncology group, the oncology fields, by performing biopsies, placing metaports, performing thoracentesis, paracentesis for diagnostic purposes. And so these are options that can be done safely away from the hospital. In addition, we can help our oncology colleagues perform local regional therapy with ablation, injecting radiation into hepatic arteries to treat liver cancer. And this is all done with no overnight stay, using microwave ablation, which is a form of burning the tumor, as well as cryoablation, where we freeze tumors. And we also inject into the artery either chemotherapy or radiation with minimal side effects. So again, I just want to thank everyone for your time. Again, my name is Dr. Safet Parik. This is my contact information. Please, you're welcome to email me or call me. Please follow me on Twitter. And I thank you for your time, and we'll transition over to the next presentation.
Dr. Eric Snitzer and Dr. Patrick Lahr will be speaking about the future of PET-CT, and I'm going to turn it over to Dr. Snitzer now, one of Windsong's radiologists.
Good morning. I'm Eric Snitzer, a radiologist here at Windsong. Thank you all for joining us today. Dr. Patrick Lahr and myself will be presenting a few topics regarding the future of PET-CT. Just a few statistics. More than 1.7 million PET examinations are performed in the United States each year. 95% are performed as hybrid PET-CT studies, and 95% are performed for oncology. Only 3% for cardiology and 2% for neurology. And 95% use FDG, that's F18 fluorodeoxyglucose, as the radiopharmaceutical. A little later this hour, Dr. Lahr will be discussing some of the newer radiopharmaceuticals. While referring providers don't need to know in-depth details about imaging technology, it is important to at least have some familiarity with new advances. The combination of CT and PET to create the modern PET-CT scanner was an important milestone in the early 2000s. Today I'll be discussing digital technology, and we'll touch on a few software enhancements as well. Well, just to review, I have to do some physics, so please don't glaze over too much. A PET-CT scan is performed by injecting a positron-emitting radiopharmaceutical such as FDG into the patient. After the uptake phase of the exam, which varies by radiopharmaceutical, the patient is positioned on the scanner. The CT portion of the exam is performed, followed by the PET portion, which is most commonly done as a series of bed steps. Some newer scanners can use continuous bed motion. Except for quiet breathing, the patient has to hold still throughout the length of the exam. So the positron-emitting radionuclide undergoes an annihilation reaction, which results in gamma rays emitted at 180 degrees. That's termed a coincidence event. The gamma rays hit the detector, which is composed of a scintillation crystal, which converts the gamma ray to light photons, and a photodetector, which converts the light photons to an electronic signal. And the electronic signals are then processed into images. Scintillation crystals, which vary slightly by vendor, can now be made smaller due to advances in manufacturing techniques. The traditional analog photodetector, the photomultiplier tube, has limits to how small it can be manufactured, which limits the spatial resolution of conventional PET images. Additionally, these photomultiplier tubes have a dead time, or a refractory period, and therefore miss many of the incident light photons. However, the digital semiconductor, the digital photodetector, can be manufactured small enough to take advantage of the smaller crystals, greatly improving resolution. Additionally, they are not limited by a refractory period and therefore have very high count efficiencies. This is what a photomultiplier tube looks like, and the digital detectors look like a chip. These silicone photodiodes can achieve one-to-one coupling with those small crystals. These larger photomultiplier tubes have to use Anger logic, which is an algorithm to improve localization. This is simply what these detectors look like. You can see that these individual crystals are organized into mini blocks, and the mini blocks into block arrays to form the detector block, which is then installed into the PET gantry. So here's an image, same patient with the brain image on the right performed on a digital PET scanner. And you can notice the greater detail of the convolutions of the gyri. So what does this all mean? It means better resolution and increased sensitivity. Again, you still don't know what that means. Of course, this being a medical talk, I have to refer to a study. This one, published earlier from the Netherlands, demonstrates the clinical efficacy of digital PET. They looked at 66 patients. They were all injected once but scanned on both digital and conventional scanners in random order. The exams were blindly read. There were a total of 238 lesions detected, with 37 additional lesions and 27 patients detected on the digital scanner. 13 of the patients were upstaged. The study concluded that digital PET improved detection of small lesions, upstaged a significant number of patients, and the images were preferred by the readers and interpreted with greater confidence. The digital image to your right demonstrates an additional supraclavicular node. You can also see that there's just all these other pathologic nodes are seen a little bit better and more sharply. Now here's the exciting part. The digital scanner gives us the option of achieving shorter exam times using a lower radiopharmaceutical dose or a combination of both. Shorter exam times lead to a better patient experience, as they are often in pain, short of breath, or claustrophobic. Additionally, there is less likely to be patient motion misregistration. We can also achieve better image quality for high body mass index patients. These two images show comparable quality in much less time. This image was obtained in 17 minutes, and the image to your right of comparable quality was obtained in 2 minutes. Now, a PET-CT is over twice the radiation dose as a CT scan, and it would be nice to try to reduce it 20 to 30%. Here's the approximate dose of a PET-CT, and here's a CT scan. This is a breast cancer patient imaged before and after treatment. You can see a metastasis here in the liver that gets better. This exam was utilized using 5 millicuries of FDG, and that is the lowest allowable dose by the FDA. The standard dose is in the 10 to 13 millicurie range. Here's an example of a patient with an esophageal cancer with a regional nodal metastasis. This shows that you can do a combination of using both a lower dose and decreasing the imaging time. The images on top were performed with less than half the dose in 25% less time. Again, you can see the esophageal tumor here. These images of a high body mass index patient with with a head and neck cancer demonstrates good image quality using 90-second bed steps on the left and slightly degraded but still acceptable image quality using 9-second bed steps on the right, thus proving that you can have your cake and eat it too. In addition to the digital hardware advances, there are also software advances, most notably time of flight. As the annihilation reactions are not perfectly centered within the PET gantry, the photons hit the detectors at slightly different times. Time of flight is an algorithm that can detect differences to 1/1,000,000th of a second, that's a picosecond, which helps to further localize the activity. This algorithm has been around for a while, but becomes more effective with the higher count rates provided by digital PET. Additionally, artificial intelligence can be used to improve image quality. The image to the right was improved by AI by discarding counts obtained from misregistered anatomy due to diaphragmatic excursion, basically breathing motion. This is made possible by the higher counts obtained with digital imaging. There is still enough data to produce an excellent image even after discarding the misregistered data. Again, you can see that there's some blur of these images due to the breathing motion, and here those same lesions appear much sharper. So in conclusion, digital PET provides additional flexibility for balancing the issues of image quality, patient comfort, and radiation safety. Many of my images were sourced from this excellent presentation. I will now turn the talk over to Dr. Lahr.
Good morning, everyone. I'm Dr. Patrick Lahr with Windsong Radiology. Pleased to be here this morning talking about PET-CT now and into the future, what we're doing currently, and where things that we envision being headed in the near future. Thanks for spending part of your Saturday with us. Prior to the year 2012, there were 4 FDA-approved radiopharmaceuticals available for PET imaging, including fluorine-18 sodium fluoride for bone scintigraphy, rubidium-82, and N13 ammonia, which were used for cardiac PET and myocardial viability. Fluorine-18 deoxyglucose was also approved prior to 2012 and continues to be the workhorse in oncologic imaging. Since 2012, there's been a veritable explosion of radiopharmaceuticals that have been approved, 8 In fact, including carbon-11 choline and fluorine-18 flucyclovine or Axumin, which are used for prostate imaging, fluorobetapir, flutometamol, and fluorobetben, which are all amyloid plaque imaging agents. Gallium-68 dotatate or NetSpot for neuroendocrine tumor imaging. Flotausapir or Tauvid, just approved earlier this year in May for tau protein imaging for dementia. And fluoroestradiol or Cerianna, which was just recently approved in May 2020 for breast cancer imaging, which we'll talk a little bit more about. Just to say that things tend to move in a glacial pace here in the U.S. It seems, as far as FDA approval, a lot of the imaging agents are available ahead of us in Europe, and that's where a lot of the research is also conducted. So currently there are estimated over 1,200 new radiopharmaceuticals under investigation worldwide, and private biotechnology companies have become involved with this, which has accelerated and probably will continue to accelerate development. So fluorine-18 sodium fluoride is used in bone scintigraphy originally in the 1960s using gamma cameras, and that was replaced by technetium compounds, which we still currently use. It was reapproved by the FDA after the year 2000 for PET imaging. So sodium fluoride doesn't image the tumor cells. It accumulates at the site of bone turnover. It can detect osteoblastic or osteolytic metastases, which is something that MDP is not that good for. It also has shown better sensitivity and specificity in detecting bone metastases than the traditional MDP bone scan. I had some cases to show. First case 1, 79-year-old male patient with a history of prostate cancer. On an outside bone scan, showed a possible metastasis in the left pubic bone. Patient underwent the sodium fluoride PET-CT, demonstrated increased radiopharmaceutical activity corresponding with a sclerotic metastasis in the left pubic bone denoted by the arrow. In addition, there was a sclerotic metastasis in the L2 vertebral body, as well as in the posterior aspects of both femoral shafts, which were not identified on the bone scan. In addition, in light of the CT images obtained as part of the PET-CT, there was retroperitoneal lymphadenopathy in the left periaortic region, as well as in the right pelvis, which ended up being due to metastatic adenopathy from recurrent prostate cancer. Case 2 is a 73-year-old female patient diagnosed with right breast cancer in 2016 and treated with lumpectomy and radiation. Bone scans showed increased uptake in the right 8th or 9th rib, suggestive of possible isolated metastatic lesion. Sodium fluoride PET-CT was obtained for further assessment. On the sagittal images, there is increased activity in several lower thoracic metastatic lesions, as well as in a right scapular metastasis, the right rib metastasis identified in bone scan, as well as multiple pelvic metastatic lesions. Case 3 is a 78-year-old patient with a history of prostate cancer with possible lytic iliac bone metastasis and outside imaging. Prostate cancer typically shows sclerotic metastatic disease. However, atypical forms of prostate cancer can show lytic metastasis. The sodium fluoride PET-CT showed a permanent lytic lesion in the right ilium, as well as multiple additional metastatic lesions, including in the skull, multiple vertebra, sacrum, pelvis, ribs, and right scapula. Here's the small left parietal bone metastatic lesion, which was lytic, as well as in several thoracic and left scapular metastases, and the pelvic bone and sacral metastases, including the right lytic iliac lesion. And there are just different sagittal and coronal images showing the way the images can be displayed. Next, I'll talk about fluorine-18 fluoroestradiol, or Cerianna, which was just recently approved a couple of months ago in May. It's the first FDA-approved radiopharmaceutical for specifically detecting recurrent or metastatic estrogen receptor-positive breast cancers. And 75% of newly diagnosed breast cancers are ER-positive. This agent is not useful for evaluation of other breast cancer receptors such as HER2 or progesterone receptors, and is to be commercially available later this year or early next year. This agent may be helpful to evaluate receptor status over the entire tumor volume in a patient, especially metastatic lesions. Endocrine therapy may be based on the ER-positive primary cancer. However, metastases can show heterogeneity of ER expression. Up to 30% of patients may lose their ER receptor expression at one or more sites after undergoing several lines of endocrine therapy. And if these metastases are not ER positive, then hormonal therapy may not be effective and chemotherapy may be necessary. If metastases are ER positive, then hormonal therapy may be effective, possibly reducing the use of chemotherapy and its side effects. In 2015, there were 160 ongoing trials of at least 30 different investigational PET agents just for breast cancer, targeting multiple elements of the tumor cell life, including proliferation, apoptosis, angioneogenesis, hypoxia, etc. So there's a lot of future research, and hopefully more radiopharmaceuticals coming available in the near future. Now we'll switch gears to prostate cancer. This is the second most common cancer in men other than skin cancer, with 165,000 new cases in the U.S. in 2018 and 1.2 million cases worldwide. It's the third most common cause of cancer-related deaths in the U.S., with 29,000 cases in 2018. So preoperative staging has been limited due to the relative low sensitivity of CT scanning, bone scanning, and MRI. Prostate MRI has been shown to be good for evaluation of the prostate gland and to evaluate the primary tumor or for patients undergoing active surveillance. Preoperatively, patients with intermediate to high-risk prostate cancers who are considering definitive treatment with prostatectomy or radiation therapy could benefit from preoperative staging. It's important to evaluate for extraprostatic extension and nodal metastases especially to determine if they may lie outside the planned radiation treatment field. There are currently no PET-CT radiopharmaceuticals currently approved by the FDA for preoperative evaluation. For recurrent prostate malignancy, there's up to 30% of men may have a biochemical recurrence within 10 years after initial treatment. Recurrent prostate cancer may only be identified as a rise in PSA level after initial treatment. And biochemical recurrence after prostatectomy has been defined as 2 consecutive PSA levels greater than 0.2 nanograms per ml 6 to 8 weeks after surgery, so very low levels. So for imaging of recurrent prostate cancer, again, conventional imaging such as CT, bone scan, and MRI may have limited sensitivity for detection. This may be in part as nodal metastases may be less than 1 centimeter and not abnormally enlarged by CT criterion. Difficulty in identifying the site of prostate cancer recurrence can delay treatment and or not allow selection of optimal treatment. So fluorine-18 PET-CT has been performed for prostate cancer imaging, but it also has limited sensitivity in most localized or early metastatic prostate cancer. Prostate or FDG uptake may be positive in aggressive forms of prostate cancer, those with aberrant histology or advanced metastatic castration-resistant prostate cancer. Another agent that was developed in 2012 was carbon-11 choline, developed at the Mayo Clinic. It only had a half-life of 20 minutes, which limited its distribution. It was only available at the Mayo Clinic, MD Anderson, or University of Washington in St. Louis. What we're currently using now, and which has been a vast improvement, is fluorine-18 fluciclovine or Axumin, approved in 2016 for identifying recurrent prostate cancer after initial treatment. It's not approved for initial staging or to evaluate treatment response. It's a synthetic leucine amino acid analog and was originally being evaluated for cerebral glioma imaging when a patient with Axumin-avid retroperitoneal lymphadenopathy was incidentally identified, and the retroperitoneal adenopathy turned out to be prostate cancer, metastatic disease. Here's a coronal MIP image showing normal distribution of the radiopharmaceutical with mild activity in the salivary glands, thyroid gland, and activity mostly in the spleen and liver, as well as some activity within the bowel. Axumin performance is has been shown to be superior to C11 choline, with an overall detection rate ranging from 40 to 70% to identification of prostate cancer recurrence. With a PSA level of less than 1 nanogram per ml, there's been reported 40% detection rate, usually due to localized tumor recurrence or pelvic adenopathy. But it's very sensitive even for picking up low levels of recurrence. Here's a study from 2017 evaluating 42 prostatectomy patients where radiotherapy decisions were changed in over 40% of patients after having an X-Men PET-CT. And in the Journal of Urology in 2019, in the LOCATE trial of 213 patients, there was a 57% detection rate for identification of recurrence, and 59% of patients had a change in their management after undergoing an X-Men scan, which is impressive. On X-Men scanning, the areas of increased uptake are compared to internal standards within the patient. For foci of activity of greater than 1 centimeter, this activity is compared with activity in the L3 bone marrow. For foci of activity less than 1 centimeter, the activity is compared with activity within the blood pool. And metastatic lymph nodes less than 1 centimeter can be detected. As well, abnormal activity in the prostate bed may suggest local recurrence of prostate cancer. Recurrence of prostate cancer in post-prostatectomy patients is most commonly at the UVJ. Prostate-sparing treatments such as radiation of the prostate can cause mild increased uptake of the X-Men within the prostate, as well as inflammation of the prostate can show some slightly increased uptake, confounding interpretation. So for detection of bone metastases, osseous metastases can demonstrate X-Men avidity, especially lytic metastasis, which is converse to what the MDP bone scan typically shows with sclerotic metastases. And these lytic metastases that can show up on the X-Men scan can be occult on an MDP bone scan. Mixed lytic and sclerotic metastases can demonstrate moderate uptake, while densely sclerotic metastases may not show X-Men uptake and may need further evaluation via conventional bone scan or sodium fluoride PET. We'll run through some cases now. First case is a 60-year-old patient diagnosed with prostate cancer with a PSA of 10.7. He was stage 4 at the time and received 6 cycles of chemotherapy and then underwent holistic medicine for 2 weeks. His PSA was remeasured later at 1.2 but was slowly increasing, and bone scan was negative. The patient underwent an X-Men PET-CT showing increased activity in the prostate gland consistent with recurrent prostate cancer, as well as there were several subcentimeter metastatic lymph nodes in the right external iliac nodal chain, left periaortic lymph node, and several subcentimeter additional retroperitoneal lymph nodes extending into the upper abdomen, which were due to consistent with metastatic disease. Case 2 is a 74-year-old patient who underwent prostatectomy in 2006, shown to have an elevated PSA of 14.8. Outside CT scan showed a 1 centimeter left periaortic lymph node, which they were of uncertain clinical significance, and subsequent bone scan was negative. Patient underwent the X-Men PET-CT here and showed normal activity at the prostate bed with no evidence of local recurrence. There was activity in a 9 millimeter left external iliac chain metastatic node, as well as increased activity within the left periaortic lymph node, which was questioned on outside images. This had also slightly increased in size to 13 millimeters. Case 3 is a 64-year-old gentleman with a PSA level of 9.7 who underwent prostatectomy in August of 2018 with a marked reduction in his PSA level, as would be expected. His PSA level, however, in the next year slowly started to rise, so the patient underwent an X-Men PET-CT. And in this case, there was an isolated 9 millimeter right external iliac chain lymph node which demonstrated X-Men avidity, consistent with an isolated metastasis paired. This node of this size could easily be overlooked or described as being normal and not enlarged, and it was only the X-Men PET that showed the metastatic disease. Case 4 is an 86-year-old patient diagnosed with prostate cancer who underwent radioactive seed placement and had a low PSA level which increased from July 2017 to 2018 and continued to climb. So the patient underwent a bone scan showing activity in the T7 vertebral body. Patient came to us for an X-Men PET-CT, and there was increased activity in the left side of the prostate gland despite the radioactive seeds consistent with suspicious for recurrent tumor. There was a contiguous increased enlargement of the left seminal vesicle demonstrating activity consistent with metastatic disease, as well as a lymph node just superior to the seminal vesicles. There was also axonal avid lytic metastasis in the right ilium, as well as in the T7 vertebral body. So the X-Men showed more extensive metastatic disease. Now we'll shift to the future, which is gallium-68 PSMA, or prostate-specific membrane antigen. X-Men has been, as I said, has been an improvement in our imaging capabilities here, and PSMA looks to improve that even more so in the near future. It's not yet FDA approved in the US, but it has had increased usage in Europe over the last decade. It's a transmembrane glycoprotein that's expressed normally on prostatic tissue, but it's overexpressed on prostate cancer cells on the order of 1,000 to 10,000 times normal. And 90% of prostate cancers demonstrate this antigen, while 5 to 10% may not. So on the left hand, the image on the left is a coronal MIP image showing normal distribution of activity in the salivary glands, lacrimal glands, thyroid gland, liver, spleen, as well as in the bowel, and excreted activity in the kidneys and bladder. The image labeled right ilium shows several metastatic lesions in there, the right iliac bone. On a different patient, on the third column, there was activity in their retroperitoneal lymph nodes consistent with metastatic disease, and the image on the far right shows diffuse metastatic disease to the bone. Although it's called prostate-specific membrane antigen, it's not exclusive to the prostate gland, as abnormal uptake can be seen in other benign and malignant processes, including skeletal processes such as fractures or hemangiomas, or other malignancies related to neovascularity. And then one of the initial studies comparing PSMA versus Axumin in 2017, PSMA was found to be more sensitive than Axumin for detection of recurrent prostate cancer, with including 50% of patients with negative Axumin scans were positive on PSMA due to detection of smaller metastatic nodes. In Europe and the Middle East, preoperative PSMA scanning is being evaluated for initial staging of prostate cancer prior to surgical intervention. And in the study of 21 patients in the last couple of years, preoperative PSMA PET-CT changed management in 52% of these patients, which is significant. PSMA is also being used for identification of biochemical recurrence in Europe, with a sensitivity described in the range of 50 to 60% when PSA levels are as low as 0.2 or 0.5, which is the minimal amount to detect or considered to be a biochemical recurrence. So it's extremely sensitive, more sensitive than Axumin. In the Journal of Nuclear Medicine in 2018, a study showed that the PSMA PET-CT changed management in 39% of 100 patients, including both patients that were to undergo radical prostatectomy or radical radiotherapy. Also in prostate cancer, monitoring the therapeutic response to treatment is difficult. PSA levels are good, but can be affected by different androgen-targeted therapies. Bone lesions are difficult to quantify in bone scan, and nodal metastases are often small and hard to note interval change on CTs. PSMA PET-CT may help in evaluation of these treatment responses to metastatic disease in the future. Now I'd like to just talk quickly about theragnostics, which is an emerging clinical discipline in nuclear medicine that combines not only a diagnostic imaging exam, but an associated specific targeted therapy. The therapeutic phase is often achieved with a higher dosage of the imaging radiopharmaceutical or the similar radiopharmaceutical labeled with a different radioisotope. This isn't exactly new, however, as radioactive iodine was the original example of a theranostic exam, such as I-131 whole body scans and I-131 treatments for thyroid cancers, or an I-123 thyroid scan with I-131 therapy for hyperthyroidism, which we're both still using today. So lutetium-177 PSMA therapy is a specific treatment for metastatic prostate cancer being utilized in Europe. Lutetium-177 is a radioisotope that has ideal physical characteristics for oncologic therapy. It emits a beta particle which gives localized radiation therapy to the tumor cells, and the range of this beta particle is only 1.5 millimeters, a short distance, and this provides localized radiation treatment with minimal exposure to adjacent normal tissue. And it also provides a gamma emission which allows for post-treatment imaging of the patient. And for people being treated for metastatic prostate cancer, there are typically 4 cycles given 8 weeks apart. So on this image, the far left image, is the diagnostic gallium-68 PSMA scan showing diffuse osseous metastases, including a large metastatic lesion in the right iliac bone and the left femoral shaft. The 4 images on the right are serial lutetium 177 PSMA scans and performed over 8 months, showing diminution of the treated osseous metastases. Now we'll switch gears again and go on to imaging of neuroendocrine tumors. Neuroendocrine tumors are a heterogeneous group of rare tumors that demonstrate somatostatin receptors. This includes carcinoid tumors and paragangliomas such as pheochromocytoma, neuroblastoma, medullary thyroid cancer, and pancreatic islet cell tumors. So currently, and for probably the last decade, we've been using indium-111 pancreatide or Actreoscan, which is a somatostatin analog and binds to the somatostatin 2 receptors. It's imaged on a gamma camera with planar inspect imaging. This imaging exam isn't ideal, as there is suboptimal imaging energy of indium-111, as well as the scan involves serial images, including multiple repeat images at 4, 12, 24 hours, and occasionally 48 hours, which is inconvenient to the patient. What we are offering now for the last several years is gallium-68 dotatate PET-CT or NetSpot. This was approved in 2016 with the PET agent binding to both the somatostatin 2 and 5 receptors. It binds 100 times more avidly than the Actreoscan agent and also demonstrates higher sensitivity than the indium-111 Actreoscan. So some of the indications for the NetSpot exam are initial staging of histologically proven neuroendocrine tumor. It's important to exclude metastatic disease, as surgery may be the only curative approach. Detect the site of unknown primary neuroendocrine tumor with known metastases, which occurs in 10 to 22% of cases, most common primary being in the small bowel or pancreas. Restaging or detecting of recurrence or monitoring treatment response in patients with known neuroendocrine tumors, or to evaluate a suspicious mass not amenable to biopsy in patient with suspected neuroendocrine tumor, or selecting patients for the lutetium-targeted therapy, which I'll talk about in a couple of minutes. So the Society of Nuclear Medicine and Molecular Imaging appropriate use criteria states that somatostatin receptor imaging, such as NetSpot, should replace indium-111 Actreoscan for initial staging, localization of unknown primary, or selection for radionuclide therapy. Meanwhile, the American College of Radiology states that the symptoms or biochemical evidence of a neuroendocrine tumor is not an indication for a dotatate PET-CT without prior conventional imaging, such as CT or MR, which most patients have before they come to see us anyway. So the biodistribution of NetSpot, it binds to all somatostatin receptor type 2 cells, including the spleen, liver, pituitary, thyroid, adrenal medulla, and the unsnip process of the pancreas, and is excreted primarily in the urinary system. As this image depicts, activity in the pituitary, salivary glands, thyroid, spleen, liver, and adrenal medulla. So we'll go through some cases that we imaged here at Windsong, including a 41-year-old male patient who had recurrent episodes of hypoglycemia and was being evaluated for possible insulinoma. Outside CT scan described a soft tissue mass posterior to the pancreatic head, and the patient underwent the NetSpot exam. The left image shows the mass posterior to the pancreatic head, which demonstrates the NetSpot avidity on the right, consistent with a primary neuroendocrine tumor. It turned out to be an insulinoma. Here it is in the coronal image showing the mass on the left, depicted by the arrow demonstrating activity on the right. Case 2 is a 69-year-old male patient with elevated liver function tests. Patient had an outside abdominal sonogram in 2019 showing multiple hepatic metastases consistent with metastatic disease, shown here. MRI of the abdomen subsequently showed multiple hepatic metastases, as well as a mesenteric nodal mass and a calcified mesenteric node. This was felt to be suspicious for carcinoid tumor, with lymphoma felt to be less likely. Here's the MR image of the liver on the right showing confluent hepatic metastases, as well as the metastatic lesions on the right and the mesenteric nodal mass. Patient underwent the dotatate PET-CT with findings consistent with metastatic carcinoid Not only did it show the activity in the liver and the spleen, here the hepatic metastases on the left and the nodal metastatic disease on the right, but we also identified metastatic nodes in the right paratracheal region, subchoroidal region within the thorax. Case 3 was a 78-year-old male patient with abdominal pain, bloating for 1 month, and weight loss. Outside CT scan showed mural thickening and inflammatory changes in the distal small bowel, as well as abnormal mesenteric nodes. Patient came to us and first had a CT enterography, which showed focal segmental mural thickening with hyperenhancement in the distal ileum and mesenteric stranding, as well as a hyperenhancing mesenteric node and a calcified mesenteric node. Again, findings were felt to be suspicious for carcinoid. Here's the CT enterography images showing hyperenhancement and mural thickening of the distal ileum, as well as the calcified mesenteric lymph node on the left and the hyperenhancing nodal mass on the right. Here are the net spot images showing the radiopharmaceutical activity in the mesenteric nodal mass on the left and the ileal primary carcinoid on the right. Another case of net spot is a 76-year-old male patient with elevated chromogranin A level. Outside CT scan showed liver masses suspicious for metastatic disease, as well as left lower lobe atelectasis and pleural effusion. Liver biopsy showed metastatic carcinoid tumor within the liver, and dotatate PET was obtained to evaluate for primary malignancy and for staging. On the left, there are multiple hepatic metastases present. On the right, there is activity seen in a right hilar lymph node in the thorax, and additionally, there was activity present within a mass within the atelectatic lung in the left lower lobe, which turned out to be a primary pulmonary carcinoid tumor. As well, we picked up a couple early lytic metastases in left rib and thoracic vertebra. So, similarly, for neuroendocrine tumor treatment, there are several options, including surgical resection, which is preferable. There is medical treatment, including octreoside or sandostatin, made by Novartis, which is an abbreviated somatostatin molecule. It's used for symptomatic control in functional neuroendocrine tumors, as well as having an anti-proliferative effect on metastatic disease or inoperable tumors, or something which in the near future or may be available in the outpatient market here is lutetium-177 dotatate, or LUTA therapy. So lutetium-177 dotatate has the same beta-emitting radioisotope for therapy, but it's also connected to the similar agent that binds to the neuroendocrine tumor cells. It was approved in January 2018 in the US and 2017 in Europe. It's used for locally aggressive or inoperable neuroendocrine malignancy, and this malignant disease should be progressing despite sandostatin therapy. The recommended dose is 200 millicuries every 8 weeks for a total of 4 doses, and it involves an infusion over 6 to 8 hours. And the dose is infused with amino acids to reduce the residency time of the agent within the kidneys, thereby reducing nephrotoxicity. There's a low emitted radiation which may allow for outpatient imaging if the patient is continent. If the patient may be discharged with standard radiation precautions similar to I-131. Some patients may, however, need an overnight stay in a hospital or some type of setting. Potential side effects include nausea, vomiting, or diarrhea, which can be severe, and possible myelosuppression, requiring monitoring of CBCs. So the lutetium-177 LUTA therapy, here's an image on the left showing diffuse hepatic metastases from a high-grade metastatic rectal neuroendocrine tumor, and the image on the right is after 4 cycles of the lutetium-177 dotatate treatment along with 5-fluorouracil, showing resolution of the hepatic metastases. In 2018, Novartis, the manufacturer of sandostatin, was buying the developer of LutaThera, advanced accelerator applications, for $3.9 billion. So Novartis evidently sees where this treatment is heading. And I'll wrap up here talking about PET imaging of Alzheimer's disease. And dementia, as we all know, the clinical diagnosis is based on physical exam and neurocognitive testing with support by imaging. Alzheimer's disease is the most common form of dementia, accounting for 68% of all dementias, with 5.7 million people afflicted in the U.S., and this number may triple by 2050. The neuropathologic diagnosis of Alzheimer's disease requires presence of both beta amyloid plaque and tau neurofibrillary tangles. Previously, we've used fluorine 18 FDG PET-CT to evaluate for different forms of dementia based on the spatial pattern of the decreased cerebral glucose metabolism. And now attention is being turned again towards the definition and identification of these plaques within the brain. Beta amyloid plaque deposition is felt to be a slow process and may extend decades before clinical symptoms present. As I previously stated, there are three radiopharmaceuticals for beta amyloid plaque imaging, including fluorine 18 fluorobutadiene or Amyvid, which I'll talk about here. The way these images are interpreted, we compare the activity of the radiopharmaceutical within the gray matter with the adjacent white matter. A negative exam shows gray matter activity less than the adjacent white matter with preservation of the normal gray-white matter differentiation, which is consistent with sparse or no neuritic plaque. A positive exam shows gray matter activity which is greater than or equal to the adjacent white matter with reduction or loss of the gray-white matter differentiation. And this is consistent with moderate to frequent plaque deposition. The top images, if you look at the far right column, the zoomed in image on the top two shows normal activity or a negative Amyvid scan with preservation of the gray-white matter differentiation and less activity in the overlying gray matter relative to the white matter. The two images on the bottom in that column show loss of the gray-white matter differentiation due to increased amyloid plaque deposition in the gray matter, consistent with a positive exam. The way these exams are interpreted, a negative Amyvid scan is inconsistent with Alzheimer's disease and reduces the likelihood that cognitive impairment is due to Alzheimer's. It doesn't say it's not due to it, but it reduces the likelihood. A positive Amyvid scan's significance is consistent with Alzheimer's disease, but can also be seen with other neurologic conditions, as well as in older patients with normal cognition. So a positive Amyvid scan does not signify Alzheimer's disease or cognitive impairment. Again, this is just a supportive exam in addition to clinical exam and neurocognitive testing. Tau proteins are a normal protein found within the brain that creates a framework of microtubules within the brain that aids in transporting nutrients. These proteins, however, can become damaged and hyperphosphorylated, changing their shape, and they aggregate into neurofibrillary tangles that disrupt communication of neurons within the brain. A recent study in January of this year showed that tau protein PET-CT more reliably predicted subsequent cortical atrophy in patients being evaluated for dementia rather than amyloid imaging, suggesting that the tau protein deposition is more likely a strong enough causative factor in Alzheimer's disease rather than amyloid plaque. And an agent was just approved in May 2020 of this year, Tauvid or flotelsapir, which is used to estimate the density and distribution of these neurofibrillary tangles. A positive Tauvid scan shows increased neocortical activity in the specifically posterolateral temporal lobe as well as in the occipital and parietal lobes, and this supports tau neuropathology. A negative Tauvid scan shows no increased activity in these portions of the brain. Here's a quick axial image of the brain at the level of the temporal lobe, and they evaluate, or the PLT area on the right-hand image is the area that they look for increased activity or tau deposition. And unfortunately, there's not many images out available for this. If you look at the right-hand green images, the middle column, the arrows point to areas of increased Tauvid deposition within the involved portions of the brain consistent with a positive scan. And I'll conclude just by saying just a couple weeks ago at the Alzheimer's Association International Conference, there was a report saying that Medicare coverage for Alzheimer's PET imaging, however, may be in doubt after a $100 million study sponsored by the ACR. And this explored whether PET-CT diagnoses could curb costs in Medicare beneficiaries, and unfortunately it didn't reach its goal. So we'll see if any of this is going to be supported and reimbursed. And I'll conclude on that.
Thank you very much, Dr. Lahr. And next up, we have Dr. David Wolf, who is Windsong's expert on clinical decision support, and he's going to give you all an update on where we're at.
Dr. Wolf here, Dr. David Wolf. Good morning, everyone. I'm going to be covering an update on appropriate use criteria and clinical decision support. I'll be covering why Medicare has mandated appropriate use criteria, where the appropriate use criteria come from, and I'll also be covering the clinical decision support mechanism, which is the way Medicare has put in place for us to meet the appropriate use criteria mandate. At the end of my talk, I'll go through a few examples of what it may look like for you as an ordering provider as you order studies for Medicare Part B patients. So one of the good things I can mention here for everyone is that appropriate use criteria only applies to Medicare Part B patients only. Medicare Advantage is not included. All your private insurance patients are not included. But if you are ordering a study for a Medicare Part B patient, it will be mandated effective January 1st, 2022, that we follow appropriate use criteria protocol. It was going to be, AUC was going to be instituted in January 1 of 2021, coming up in a few months, but because of COVID, the government has pushed it back 1 year. We are in currently, and will continue through 2021, what's considered a testing period, and Medicare is asking all of us to pretend that it is in place now, so that over the next year we can work out any bugs or try to design the system so it's a little bit more seamless and easy for everyone to use. So what is appropriate use criteria and clinical decision support mechanism? If you order an advanced diagnostic imaging study, and that's defined as a CT, an MRI, or any nuclear medicine study, including PET-CT, for a Medicare Part B patient, the ordering provider must consult appropriate use criteria through clinical decision support mechanism, which has been approved by CMS. You must provide this AUC information to the radiology facility because the facility is mandated to report the results of that consultation on their Medicare Part B claim. That information will be transmitted through electronic means of a QQ modifier to the CPT code. And the QQ modifier confirms that the ordering professional consulted with clinical decision support criteria for the service, and also what the results of that consultation was, and that those results were communicated to the imaging facility. The purpose of the appropriate use criteria program is really to enable you to order the most appropriate test for your patient. And you certainly can go through the AUC program to determine that. And we as radiologists, of course, are always here in the background to help you if you have particular questions with regards to what your most appropriate test is. CMS is going to compile and use the appropriate use criteria data that they have collected to identify ordering outliers who would then become subject to prior authorization. So the plan is to try to get you to follow appropriate use criteria, which is the appropriate thing to do per clinical and imaging experts. But if you do fall outside the recommendations, you still can order the test and have the test performed. It's just that CMS is going to be keeping a log on all of the providers and looking for providers who are outside the norm or ordering studies on a consistent basis that do not apply to what appropriate use criteria considers the appropriate imaging study for a particular clinical indication. The statutory background on this, I think, is a little important to understand in that the AUC program was mandated by Congress. So Medicare is following a congressional mandate, which was passed in the Protecting Access to Medicare Act, which is also known as PAMA, of 2014. Within that act, they mandated that appropriate use criteria be employed to attempt to cut down on the cost of unnecessary or inappropriate exams. So that's the rationale behind it. And it also replaced what used to be known as the Sustainable Growth Rate Law. And for some of the more senior members of the medical community, you may remember something that was called the doc fix that had to be passed every year, because the Sustainable Growth Rate Law, which was instituted in '97 and ended, was replaced by PAMA, tied the total expenditure of Medicare to the national inflation rate. And as you know, medical care has been exceeding the inflation rate by a good percentage over the past, 20 years. So what that required was that towards the end of this law, for physician services and for PA services, they were starting to run calculations where we were looking at 30 to 40% hits to the reimbursement to the physician. And so to avoid that and to avoid physicians dropping out of the Medicare program, every year Congress was forced to pass a, quote, doc fix to reinstate sometimes most of the reimbursement for the service. But they got tired of doing that every year. It was always a political battle, so instead they've instituted appropriate use criteria program as perhaps a more scientific and targeted way to help keep the rate of growth of Medicare expenditures down. So where do appropriate use criteria come from? It's not just something which is promulgated by Medicare and Medicaid. It's developed by national professional medical societies using peer review, literature review, to reach evidence-based and/or consensus-based criteria for the imaging that you order. And because there are multiple professional societies that are producing the criteria for what they consider to be the most appropriate test, out of that there actually are multiple clinical decision support mechanisms that CMS has approved. I believe it's 10 or 11 at this point of approved clinical decision support mechanisms. The one that I'm most familiar with is of course the radiology, the radiology promulgated appropriate use criteria, which radiology has been working on for years, even before this program got started. So clinical decision support mechanisms, what are those and how do they work into the AUC? The AUC, appropriate use criteria, are the professional recommendations of what the appropriate imaging is. How do you reach that and how do you incorporate that? Well, it's incorporated through a consultation of what Medicare calls clinical decision support mechanisms. And these are interactive electronic tools that clinicians will use to obtain the appropriate use criteria information. For the most part, these clinical support mechanisms are being incorporated into the EMR. So they're being incorporated into Epic and Cerner and MedEnt. And I've had a chance to see some of the beta attempts of the computer programs incorporating appropriate use criteria into the EMR. Basically, if you have your patient and you're in your EMR and you're about to order a CT scan or an MRI or a PET-CT scan or nuclear medicine study for your patient, the EMR knows what insurance your patient has. So if they have Blue Cross Blue Shield, this doesn't apply, and you'll just order your study as you normally do in that scenario. If they have Medicare Advantage, it will ignore it. But if it's a Medicare Part B, which I'm told in our practice is about 10% of our patient population, the EMR will direct you to answering the questions that the appropriate use criteria program is looking for to decide whether or not your study is appropriate, may be appropriate, or not appropriate. And there's basically three things that the AUC wants you to enter for data points, 3 or 4, and that's the age and sex of the patient, the clinical indication, and the type of exam that you're ordering. These clinical support mechanisms will address most of the common and important clinical scenarios that we face. There always are, of course, unusual situations that may not fall into a particular category as outlined by appropriate use criteria. But I want to reassure people that within your EMR, it will prompt you when an AUC situation has come up and when you have to address it by answering some questions for the clinical support mechanism. The other thing I'll mention here real quick is that, and this is a regulation that just came down recently, and that's that what happens if you enter your information, you want to order a test for a patient, and it comes back not appropriate. Well, CMS is allowing those to go through. It will track you, but it will still give you the authorization to proceed even though it fell outside the appropriate use criteria. So the clinical decision support mechanism will provide the ordering physician feedback on whether the surface ordered adheres to AUC or not. And actually it gives three levels. It gives yes, it adheres, and it scores those as 7, 8, 9, that the experts agree that if you're worried about ectopic pregnancy in a young female, pelvic ultrasound is the way to go. That's going to be a 9, and it's going to come back with a green bar. It may come back with something which is called may be appropriate, which is a yellow on the yellow code, and those are classified as 4, 5, 6, may be appropriate in certain clinical situations, and probably, if you think it's appropriate, then go ahead and order it. Then there's a red code, which is appropriateness levels 1, 2, 3, which most experts would agree, hey, that's not really the appropriate test. And sometimes the CDMS will suggest other more appropriate studies that you should be thinking about doing, and probably stay away from the 1, 2, 3 red situations that are not clinically appropriate for the information you've entered. Once you've entered this information into the clinical support mechanism, or basically your EMR, it'll supply the QQ modifier. The QQ modifier will include information that you have consulted the results of what the results were, that it was yes, approved, might be appropriate, or no, it's not appropriate. That information is sent to CMS. Your national provider identification number of the ordering professional for this study is also sent to CMS because they're tracking us, they're watching us. And there's also a unique consultation ID number, which they're getting as well. And the facility, whether it's your hospital emergency room or your friendly neighborhood radiology provider, needs that QQ modifier to be reimbursed by CMS. If it's not provided, the the service is rejected for payment by CMS. This will go into effect January 1st, 2022.
Deep in salvatory oral dead.
Sorry. I have a little timer going in the background to make sure I'm not going over time. 16 minutes, and I think I have about, probably 7 minutes to go.
Okay.
Priority, let me back, did I mention priority clinical areas? Maybe not. Okay, so one thing, as I mentioned, CMS is watching us. And there are 8 clinical areas that CMS has identified as priority areas that they've already told us ahead of time that they will be watching us to see, are we ordering appropriate studies for these conditions? And these are the conditions that they've told us they will be watching for. So I guess I would give as a heads up, try to be vigilant when you're ordering for the 8 areas they'll be looking at: coronary artery disease, suspected pulmonary embolism, headache, which can be a big one. I'll go through that a little bit. Hip pain, low back pain, shoulder pain, neck pain, all these very common, I'm sure, and also lung cancer. So settings where appropriate use criteria applies. It applies in your physician office. So any outpatient physician office, it'll apply for your Medicare Part B patients. It also applies in the emergency room, hospital outpatient departments. It does not apply for inpatients. Ambulatory surgical centers and also independent diagnostic testing facilities are also included. I'm not sure how much imaging goes on in those facilities, but it applies there too. So the payment QQ modifier is the proof that you have consulted clinical decision support, and it comes back with a grading as to whether or not your study is considered appropriate, might be appropriate, or not appropriate. So it shows you you've consulted it, and there are several varieties out there because there's different medical societies that have produced these, and I haven't seen it, but I've been told by consultants that you can enter the same information in one appropriate use, or clinical decision support mechanism, and it may say not appropriate, but if you go to a different medical society, that appropriate use criteria may fall under an approved or might be approved criteria. So there is, of course, some variability. I think, if I understand it correctly, the EMRs are for the most part picking one, so I don't think there'll be much chance for you to go in and out unless you become very savvy with this and go to the various websites. Most of these societies, including the Radiology Society, have set up independent websites that you can go to get your appropriate use QQ modifier through other means. As I mentioned, it'll include your national provider identification number, whether or not it adheres to the service. And this is the last thing I have here. This is important, is that Medicare has a regulation that the provider who's ordered the study can delegate the consultation, but it has to be delegated to clinical staff. They've made it pretty clear in their regulations that they don't want physicians or PAs or ordering providers to be delegating this to a secretary in your office to obtain the AUC information. They've also made it clear that they don't want the radiology office to obtain it as well. So unfortunately, we can't help you directly there. As radiologists, of course, we're always available for consultation to perhaps help guide you through some of the questions or issues to get what the appropriate test is. There are exceptions. The exceptions actually are pretty minor. Medicare is pretty strict. There's a little bit of talk about hyper-emergencies. If somebody's coming into the emergency room with major motor vehicle accident, then it's, slap them on the CT and scan them. They don't want you wasting 2 minutes, getting appropriate use criteria, that yes, someone with a suspected depressed skull fracture needs a head CT. Just scan them, I think they are going to ask that you retrospectively then get the appropriate use criteria that my patient's head who is squashed needs a head CT. It also does not apply to inpatients. They talk a little bit about, although it's not real clear in the regulations, about provider hardships, including insufficient internet access. I suspect that's going to apply mostly to places that are very rural that don't have internet access. EMR issues. Most of the major EMR providers are embedding this in their EMRs, so that's probably going to be less of an issue. Or extreme and uncontrollable circumstances. Perhaps they mean during hurricanes or tornadoes. In those instances, and your internet is down, you don't need to bother with getting your appropriate use criteria. I wanted to show you some examples, and this is one of the internet sites, CareSelect, that we use. Unfortunately, I can't share the screen of an online, how it looks to enter the information, and then what the clinical decision support mechanism information comes back as. So since I'm not able to access it online real, I ran a few scenarios and have taken screenshots of what this might look like. Of course, this is going to look different in each person's individual EMR, but I'm going to go ahead now and show you, for instance, the sort of information that they're looking for. And they do give basically two different ways to access the AUC through your CDMS. One is you can enter service. First you enter this is mandatory, the age and sex of the patient. You got it. So I have a 65-year-old male, and I apologize to Anna that I'm using her account here. But you enter the age and sex, and then you can either enter the type of service that you're looking for, or if I skip ahead a slide or two, here's another option, 30-year-old female. I didn't select the service, but instead I selected the indication, migraine headache. And so it comes up with various choices that I can pick for migraine headache of what type. But anyway, let me go back to, I have a 65-year-old male in my office. He's been smoking for 50 years, one pack a day, and I want to order a CT scan for this patient because he's been smoking for 50 years, and we think that's the appropriate thing to do, particularly a low dose CT. So I enter that, and I entered a CT scan, and I clicked low dose lung cancer screening is what I want to do it for, and my clinical information is screening. And these are the various possibilities that come up for me to click. Now I'm not going to click it because I'm not live, but if I had clicked lung cancer screening, less than 20 pack year smoking history, no risk factors, it's going to come back and tell me, no, don't order it. That's not appropriate. But if he's greater than 50 pack year history, then, and that's what I did select on the next screen, that is appropriate because he's got more than 30 pack year history and he's 65 years old. So when I click it, I don't know why this came out small. I don't think I can, yeah. Unfortunately, darn it. Don't know why that screen didn't come out proper. But it's supposed to show that this is a 9, low dose chest CT. That's the appropriate test to order. And the one below it is CT scan with contrast, and that I believe came back with a 2, that it was not the appropriate test. So you want to order low dose, no contrast, not a CT scan with contrast. It kind of tells you to do that. There's a button over here, I can't show it because it got cut off, where I say select this service. I selected this service, and the CDM came back with my AUC information, which is decision support number. This is the provider identification number, what doctor it was, age of patient, the study we're doing, what the history is. The score came back as 9. I mentioned 789 is appropriate. So the consultation result adheres to appropriate use criteria. It gives us our authorization code, and it gives us our QQ modifier. And you can't see this button here again because it got cut off, but that down here says paste to my order. So within your EMR, it's automatically transmitted to your order, and then when you send the order gets sent to the radiology facility. They have all the information they need. We do the low-dose CT scan, and you get your results back in 24 hours, at least at Windsong, hopefully. So I have less than 5 minutes, so I'll go through one more example. I entered a 30-year-old female. I didn't select a service, but she has migraine headaches. And I have various options here within the headache that the CDMS comes up with, the clinical decision support mechanism. Headache chronic with new features, headache chronic, no new features, classic migraine, new or worsening headache with a history of cancer. All these choices are going to give me different results as to what is the appropriate or not appropriate test to do. In this case, it was a 30-year-old female. She's got migraine headaches, and she has no new features, but she was really pushing me for a CT or an MR or something. She just, is tired of the headaches and wants to know for sure she doesn't have a brain tumor or something. So so I did select chronic, no new features. And and unfortunately it got cut off again. None of these studies were appropriate, were a category 7, 8, 9, or even a 5, 8, 6. But I think I chose MR brain without contrast. And when I clicked MR brain without contrast, it comes back with MR brain because it did not adhere. CMS will still let us order it and do the study, but it wants to know why, or at least what your rationale is. So you can click, I consulted with radiology, a specialist, disagree with the score, patient complex condition, etc. And so you can still order the test, and it will come back with all your numbers, the information. The consultation did not adhere. The reason why is that I consulted with a specialist, and they asked me to do it, and you then paste this to your order, and the study can be done, but they will be tracking us to make sure that we're not ordering an inappropriate number of those inappropriate exams. So within that, I think I had one more study here, but I'm going to skip over that, and I'll just end with a picture of my little fiber farm. You're seeing pictures of various, mostly fiber animals. That little bunny at the very beginning is real. That's an Angora rabbit. She gets sheared 3 or 4 times a year and produces about 2 pounds of super high quality wool, super fine, super soft. The sheep are Southdown baby dolls that produce about 6 to 8 pounds of wool in the spring when they get sheared. And their wool is a little bit thicker and scratchier. They're excellent wool for socks and blankets. And the plan is to mix the bunny wool with the about 25% bunny wool with 75% of the sheep's wool, and make a product, a wool, which will be similar to a merino wool, very nice and appropriate for sweaters and scarves and things like that. So that concludes my talk. If there's any questions, open and available.
Good morning. I'm Anna Chen, and as Gina said, I am one of the main mammographers here at Windsong. I've been here for 16 years, and it's my pleasure to talk to you this morning about male breast cancer and the transgender population and current screening guidelines. For topics of discussion, we are going to talk about first general statistics of breast cancer in men. We'll be talking about the male breast and gynecomastia, because I think you need a little bit of an understanding of the breast tissue in a male breast to have a better understanding about male breast cancer. And then we're going to talk about risk factors, symptoms, diagnosis, treatment, how male breast cancer differs from female breast cancer. We're going to switch gears a little bit after that and talk about the transgender population, which I find fascinating, and it's a newer topic that's been coming about. We'll talk about current guidelines for both, and then we'll discuss genetic testing and what we should consider for revisions of the current guidelines that are out right now. So first, male breast cancer, we all know, accounts for about 1% of all breast cancers. In 2019, there were 2,670 men that were expected to be diagnosed and about 500 men that were expected to die from breast cancer. And the incidence has increased by 20 to 25% in the past few decades, and it does continue to rise. We all know that the lifetime risk is about 1 in 1,000 for a man versus 1 in 8 for a woman. And although it's uncommon, it can be deadly. In the American Cancer Society in 2018, more men died from breast cancer than they died from testicular cancer. So in regards to breast development, the prepubescent boys and girls, they both have a small amount of breast tissue. And it's in the peripubertal period in boys, they have a 30-fold increase in testosterone levels, which causes significant involution and atrophy of the ducts. Versus girls, where the ovaries produce the hormones that stimulate the ducts to grow and lobules to form at the ends of the ducts. So boys and men will still have low levels of female hormones, which is normal, but the breast tissue doesn't grow significantly and it's non-functional. It contains some ducts, but very few, if any, lobules. During puberty, there is a transient elevation in estradiol, which causes proliferation of the subareolar ducts and stroma in boys. And a lot of the times you'll have these boys that are going through puberty say that, or come to you and say that they have a palpable lump. And it'll feel like a little disc-like area directly behind the nipple. It usually resolves spontaneously as the testosterone levels continue to rise, and it counteracts these transient estradiol effects. So in a normal adult male, their breast is comprised of just skin, subcutaneous fat, atrophic ducts, and stromal elements, and they don't have any Cooper's ligaments. Breast lobular development, which is stimulated, like we said, by estrogen and progesterone, is rare. So conditions from lobular proliferation are very uncommon in men, and that includes fibroadenomas, phylloides tumors, invasive lobular cancer, and lobular carcinoma in situ. Whereas when they do have proliferation of ductal and stromal tissue, they are subject to gynecomastia, invasive ductal carcinoma, DCIS, and papillary carcinoma. So probably the most common abnormality we see is gynecomastia in the male breast, and it's caused again by the proliferation of ductal and stromal tissue. And again, it's most commonly seen in puberty and senescence, but can manifest at any age depending on precipitating factors. Symptoms can be unilateral or bilateral, and the presenting symptom is usually breast pain, mass, or enlargement. So there's a whole host of different causes of gynecomastia, and usually it's from the typical fluctuation or the differentiation between the hormone levels. And their categories are physiologic, drugs, cirrhosis, hypogonadism, neoplasms, hyperthyroidism, chronic renal disease and dialysis, and of course idiopathic causes. And you can see the list of all the different subcategories that can cause gynecomastia. On clinical exam, it's usually concentric and easily compressible, mobile soft subareolar mass versus breast cancer, which is typically eccentric to the nipple areolar complex. And then there's pseudogynecomastia, which is just overall enlargement of the breast rather than actually a discrete mass. With gynecomastia, there's three typical characteristic patterns: nodular, dendritic, and diffuse and glandular. Nodular is considered the early phase. You have a florid phase of ductal and stromal proliferation. It's usually less than a year. It is typically reversible if the stimulus is eliminated. Mammographically, we see a typical fan-shaped subareolar density which blends into the surrounding subcutaneous fat. And again, histologically, it's characterized by proliferation of the intraductal epithelium, some periductal inflammation, and surrounding edema. The dendritic phase is considered a later phase, and it's called the fibrotic phase, and it's usually irreversible. Mammographically, we see a classic flame-shaped subareolar density, which radiates from the nipple, and you have linear projections that interdigitate into the deeper adipose tissue, and it can extend up into the upper outer quadrant. And histologically, it's characterized by stromal fibrosis and dilated ducts. Diffuse glandular, we see in patients that are receiving very high-dose estrogen therapy. Mammographically, it looks like a heterogeneously dense breast, and on ultrasound, it can be difficult to separate it from malignancy, as it does cause like a shadowing appearance. Clinically, you can differentiate this from breast cancer because, again, there's an absence of typically absence of a discrete mass and the secondary signs that help distinguish it from cancer. This is just an example mammographically. Typically, there's the nodular appearance. Again, this is the fan-shaped appearance that extends directly from the nipple versus the dendritic phase, which is the interdigitating fingers, or we call the flame-shaped appearance. And this is, again, the diffuse glandular appearance. Gynecomastia is usually bimodal. Here, first occurs at puberty and then near the age of 50, and it's usually unilateral. Mammographically, actually, we typically see it bilaterally, but it is usually asymmetric, as opposed to breast cancer, which usually is seen unilaterally. Mammography helps differentiate between benign and malignant with very high sensitivity and specificity. So whenever someone comes to us, a male patient, we typically, if an ultrasound is the only thing that's ordered, we typically will still start with a mammogram because that helps us put the two together and helps us differentiate between the two. Treatment, usually we evaluate the physiologic cause, and once you identify it, you hope to remove that as long as you are still in the early phase and not in the reversible fibrotic phase. And it hopefully spontaneously regresses in a majority of patients. If it does not, then the treatment, if the patient wishes to proceed, is a reduction mammoplasty. So we're going to now switch gears to breast cancer in men. And again, its peak incidence is at the age of 75. And again, it's usually due to a hormonal imbalance where you have excess estrogen in relation to the androgen. These are the various causes that can cause hormonal imbalance, hormonal medication, obesity. We all know that obese patients, the fat can be peripherally converted into estrogen. Then you have healthy alcohol, again, liver, testicular, Klinefelters, and occupational exposure and radiation exposure is a risk factor. Ethnicity has also been found to be a risk factor. There is higher incidence among African American men. They're more likely to be diagnosed younger and less likely to undergo treatment. 76% higher risk of death compared to similarly aged white men. And the difference, they say, is partially attributable to socioeconomic status and the access to care. There is a well-known that Ashkenazi Jewish descent men are at higher risk because they do have a higher prevalence of carrying the BRCA1 and BRCA2 germline mutation. Strong family history, and again, genetic predisposition are risk factors. If you have a family history of breast or ovarian cancer, especially in a male relative. Men, again, can inherit the genetic mutation. It's most commonly the BRCA2 mutation. If they carry it, they have a lifetime risk of developing breast cancer of 8%. BRCA1 carriers have a 2% increased risk, and that is opposed to an average man that usually carries only a 0.1% risk of developing breast cancer. Symptoms, typical lump or swelling, nipple retraction or inversion, skin dimpling, redness and scaling of the nipple discharge, and axillary lump or swelling. Diagnosis, more so by medical history and physical exam. Medical imaging, again, as I said, we typically like to start with a mammogram and an ultrasound and do those together. Occasionally, a breast MRI will be performed, and obviously you need a needle core biopsy to make and confirm the diagnosis. The challenges with male breast cancer is there's typically a lack of screening. Again, lack of awareness and education. Men tend to delay and avoid clinical care in general, so duration of symptoms tend to be about 10 to 30 months before they come in. And about 40% of male breast cancers manifest already as stage 3 or 4 disease once they've been diagnosed. So men have the breast tissue, because they have so little tissue there in the first place, the tumor, if they have one, tends to be close to the skin and the nipple, which increases the likelihood of dermatolymphatic spread and early metastasis. The male breast typically abuts the skin and the pectoralis fascia, which shares the lymphatic drainage to the skin by way of the subareolar complex and also into the axilla. And therefore, you have a high propensity of lymphatic invasion, you have a high propensity to develop the skin, you have a high propensity for nipple involvement, and again, you commonly have associated axillary nodal metastasis. Treatment, surgery is the mainstay of treatment. It is called a modified radical mastectomy. The nipple and areola and all of the breast tissue is removed, and the muscles in the chest are left alone. Again, lymph nodes are removed. A lumpectomy, which is breast conserving therapy, is not usually done because men's breasts are typically very small. Radiation, hormonal, and chemotherapy are also in lines for the treatment for breast cancer. Now, it has been known that it has been studied and shown that actually male and female breast cancer is typically not the same breast cancer. There's been a stage-matched disparity in survival of men and women with breast cancer, and it's not accounted for by more advanced manifestation of breast cancer alone. Data has been shown that male breast cancer differs in tumor biology and genetic signatures. There was a study that was done from the Veterans Affairs Central Cancer Registry that found the largest disparity actually was in patients between stage 1 and 2 disease. The median survival was 6.1 years for a male breast cancer patient compared to 14.6 years for a female breast cancer patient, which really highlights the need for the detection of early detection of breast cancer in men. The additional data suggests that men fare worse in the setting of recurrent disease, with the male median survival of only a year compared to female survival of 2 years with recurrent breast cancer. Again, analysis from data from the SEER program, investigators suggested that there was because of the continued increase in incidence of male breast cancer, with a concurrent decline in incidence of female breast cancer in the U.S., that is not just related to fluctuations in breast cancer risk factors shared by men and women, but more likely attributable also to current divergent approaches to diagnosis and treatment between male and female breast cancer. And then male breast cancer, they've found is overwhelmingly ER positive. The most common histologic subtype, ER positive, PR positive, HER2 negative. And they found that not all male patients with ER positive cancer received tamoxifen treatment. Triple negative breast cancer is very rare compared to women, and it is predominantly ductal in origin versus lobular, which was what we discussed when you had male breast development. Again, it was mostly ductal, and they very rarely had the lobular development, which makes sense for it to be a rare process. They found that the histologic grade of tumor doesn't necessarily correlate with the clinical outcome of male breast cancer, whereas women, this has been found to be an established prognostic indicator that has been correlated with disease-free survival and overall survival. Tumor oncogenetics differ. Although ER positive and HER2 negative, they have found that there's a luminal molecular subtype difference. Men are more likely to have luminal A-like and luminal B-like molecular subtypes rather than the basal-like subtype, which are good prognostic indicators. They have found the PALB2 gene, which is a partner and a localizer on the BRCA2 gene, is found in 16% of male patients, and it's only found in 1% of female breast cancers. The MC gene, which is a BRCA1 interacting transcriptional repressor gene, is found in 35% of male patients and only 13% of female patients. There's more data that shows that breast cancer in men is not the same disease as women, as in women, and male breast cancer specific data is needed to optimize diagnostic and treatment strategies. And it's obviously hard because of how rare male breast cancer is, but obviously we need more studies to help differentiate this, and there's many factors as to why male breast cancer is felt to differ from female breast cancer. So current screening guidelines from the National Comprehensive Cancer Network, or what we call the NCCN guidelines, they do have guidelines out for patients that are male carriers with a breast cancer mutation. And their guidelines currently are to do an annual clinical exam and a self-breast exam starting at the age of 35. Start prostate screening beginning at age 45 because these carriers are at increased risk of prostate cancer and pancreatic cancer, as well as melanoma. They actually don't recommend regular mammography just because of the limited data supporting imaging in men. But it has been found that men who tend to have a high family history and risk factors, they do usually end up pursuing mammographic screening, although it is not a recommendation currently. From a different society, the American Society of Clinical Oncology from 2019, they have a different set of guidelines. They recommend ipsilateral annual mammogram offered to men with a history of breast cancer who are treated with lumpectomy, regardless of their genetic predisposition. They recommend a contralateral annual mammogram offered to men with a history of breast cancer who carry a germline mutation. Breast MRI is typically not routinely recommended, even though BRCA1 and BRCA2 if men who carry these genes have a cumulative increased risk of 1.2 and 6.8%. Those values are considered lower than the risks experienced by women carrying these mutations, but they're still substantially higher over the average man. So instead of recommending an MRI, they do recommend the contralateral mammogram instead. Other factors against MRI is that men, again, have typically a lot less breast tissue, and there's lack of data right now demonstrating the improvement in survival of this screening test in women, although I think that data should be coming out within the next several years, and then the potential for false positives. Men with breast cancer should be offered genetic counseling and genetic testing. And I did want to note that in the draft that was put out by the ASCO guidelines, the contralateral annual mammogram in men without predisposing genetic mutations, it didn't reach the consensus of 75% or more, and that's why it was not in the draft recommendations. Just note that the lifetime risk of a secondary breast primary among is approximately 2%, and this is higher than the risk among the general population of men, but lower than the breast cancer risk among general population for women, and that's why that was not a recommendation. So I'm going to show you a set of 5 cases total throughout the presentation. And the interesting thing is that these cases actually all occurred since June of this year. So they're very recent cases, and actually some might be going on currently. So this is a case of a 33-year-old male that presented with right palpable lumps. This is a picture of the mammogram, and again, we always start with the mammogram. This is the right side, this is the left side. We put radiopaque BB markers over the palpable lumps, and he had 2 lumps. One is this rounded mass here, and there's another mass here within the upper outer quadrant of the right breast. You can see this is directly posterior to the nipple, whereas this one is in the upper outer quadrant. And just note, on the left side, you do see a little bit of tissue here. So like we said, gynecomastia in a male is typically can present bilaterally, but it is usually asymmetric. But we usually use both sides. We do a mammogram on both sides and not just the side of concern because it helps us do a comparison. So once the mass was found, we did an ultrasound, and the ultrasound of these 2 masses on the right, they were biopsied and subsequently shown to represent invasive ductal cancer. We typically also ultrasound the other side just to take a look and again compare. This is the nipple here, and there is a sliver of tissue here. Although it has a typical appearance of gynecomastia to us, it was recommended, the surgeon did request that a biopsy be performed on this tissue here just to be on the safe side, and it did prove to be gynecomastia. So case 2 is a male patient that came with a palpable right breast mass. Again, we started with a bilateral mammogram. You can see the mass here directly posterior to the nipple. I did a little zoomed in magnified view, and there are some pleomorphic calcifications associated with the mass. This is the nipple here. And then mammographically, the margins are fairly indistinct when we take a close look. So it was suspicious mammographically. And we did an ultrasound as well. This is the lobulated mass that is directly posterior to the nipple. This is the nipple. The biopsy was performed and showed invasive ductal carcinoma. Whenever we find a concerning mass on a male or a female, we usually check into the axilla just to check and see if the lymph nodes look normal. Normally, a lymph node this is the lymph node here, it has a fatty echogenic hilum, but when they start to become abnormal, the cortical margin is what we measure. You have all sorts of different sizes of a lymph node, so the size itself actually doesn't matter. It's more the morphology in terms of if it becomes abnormally rounded or if you have an abnormally thickened cortex. A normal cortex that we take is 3 millimeters or less. If it starts to increase over that or become asymmetrically thickened, that is worrisome, and this one measured 5 millimeters in cortical thickness. It was biopsied, and it was shown that it was not metastatic disease, and it was just a reactive lymph node, and that is a common finding, and that's why we do recommend the biopsy to prove if we're metastatic disease versus reactive disease. This patient did happen to have an MRI exam. I'm not sure why we proceeded with the MRI. It was probably requested. But you can see the tumor here. This is the right side. This is the left side. This is just the nipple. And the tumor shows sharp enhancement or takes uptake of the contrast. And you can see this large feeding vessel extending up into the chest. And it kind of demonstrates how you can get lymphatic spread to tumors into the internal mammary chain, which is another area that breast cancer has a typical propensity where it can metastasize to the chest, and it can actually bridge over into the other side as well. So this is the third case before we switch topics. This is an interesting case in that it's a male patient that came with a left palpable mass, and you can see here, this is his left side, this is the right side. Is a 23 millimeter rounded high density mass. Margins were indistinct, but if you take note, again, we always do the other side for comparison. There was this little small mass here behind the nipple on the right. And so he was not symptomatic on the right, but had this palpable mass on the left. So an ultrasound was done. This was the mass on the left that was palpable. It's got solid and cystic components. It was biopsied and shown to represent fibrocystic changes in chronic mastitis, which is concurrent with the imaging appearance. This was the mass on the right. This is the nipple, and this was the small mass adjacent and eccentric to the nipple. This was biopsied, and we were able to detect a 6 millimeter invasive ductal carcinoma before it was palpable and clinically identified clinically. So we're going to switch gears now to the transgender population. And again, as I said at the beginning, this is actually a newer topic for me and actually for the community, I think. And it's important to understand terminology first. So the transgender is an umbrella term for individuals whose gender identity and or gender expression differs from their assigned sex at birth. The number of transgender individuals is estimated from 8 million to 25 million globally, and in the United States, 1 to 1.4 million. Terminology, the term transgender should always be used as an adjective and never a noun. The pronoun used for transmasculine individuals is he or him. Transfeminine individuals, she or her. The gender non-binary individuals, the plural is they or them, and singular is ze or zer. Transition is a process by which the individuals change their gender expression through changing their physical appearance. And it's been learned actually that the word transition is kind of offensive to some of the transgender patients. Gender affirming surgery are surgeries that individuals undergo to change their physical appearance to better match their gender identity. So that includes orchiectomy, hysterectomy with bilateral salpingo-oophorectomy, facial feminization surgery, chondrolaryngoplasty, and top surgery, which is elective breast removal of the tissue and chest reconstruction. Cisgender are people whose gender identity and gender expression reflect the sex that they were assigned at birth. So now that I've given you the quick education of terminology, transgender women are a large subset that use feminizing hormone therapy to suppress endogenous testosterone. These hormonal changes include breast growth, slowed growth of body and facial hair, fat redistribution, and decreased testicular growth. And they experience varying breast development. Apparently they go through Tanner stages, but they never fully reach the Tanner 5 stage. Development starts as a breast bud, which occurs within the first 3 to 6 months after beginning hormonal therapy. Maximum growth occurs 2 to 3 years after the start of hormone therapy. And when maximum phenotypical changes are obtained, they lower them, and there's a lower maintenance dose required. But it is typically a lifetime dose. Mammographically, there is a range of density levels. There was a study that was done of 50 transgender women. 94% were administered estrogen, and 60% were judged to have dense or very dense breast tissue. But there didn't appear to be a correlation between the density and the amount of estrogen or the duration of the estrogen therapy. So those on higher levels of estrogen develop breast tissue similar to cisgender women. They form ducts and lobules and acini. And it's not the same as gynecomastia, which only involve ductal and stromal hyperplasia secondary to the mild estrogen and androgen ratio. We should never use gynecomastia as a term when reporting breast tissue in transgender women. Since it is hormonally driven breast tissue development similar to cisgender women, these women will develop both conditions related to lobular development and ductal development, which include, again, fibroadenoma, cysts, and PASH, and the malignant conditions of invasive ductal, poorly differentiated adenocarcinoma, and malignant phylloides. The relationship between exogenous hormone therapy and breast cancer is not well defined, and there is mixed data on it. The awareness of the breast cancer risk was extrapolated from the documented increase of breast cancer risk in postmenopausal cisgender women who take short-term combined progesterone and estrogen hormone therapy, and supported by the increased rate of reported breast cancer in general in transgender women. There need to be a lot more studies done and clinical trials to get actual data on transgender women rather than the extrapolated theoretical risks. Screening guidelines, there are actually guidelines that are out there. There are 3 societies that we'll touch on in a little bit, but the guidelines vary according to the age and the risk factors, including the duration of hormonal therapy. They do recommend annual or biennial screening starting at the age of 50. They say to consider reducing the age of onset of screening or increase in frequency depending on genetic conditions and other risk factors. Diagnostic evaluation is similar when they have a problem. For transgender men, they receive medical hormone therapy to induce masculinizing changes while minimizing the feminine secondary sex characteristics. The mainstay of therapy is testosterone and is delivered either intramuscularly or subcutaneously. Long-term therapy reduces the breast glandular tissue and it promotes formation of connective tissue. And top surgery, which we discussed, removes the breast tissue, and it can include male chest contouring and free nipple grafting. There is some residual breast tissue that may remain, and you may preserve the nipple areolar complex. Many surgeons advocate for a full cancer risk assessment and do order imaging prior to the surgery just to make sure that there's no evidence of cancer. The effects of testosterone therapy are unclear. Some research theorized that the testosterone could increase the risk of breast cancer, and that's based upon studies of cisgender women that document associated higher circulating endogenous androgen levels and breast cancer. However, cisgender postmenopausal women and transgender men have demonstrated no increased risk of breast cancer incidence with exogenous therapy, and there's controversy where actually testosterone may reduce the risk of breast cancer. So obviously more studies are needed because we have got conflicting information whether testosterone increases or can be a preventative measure. Current screening recommendations, again, vary according to age, risk factors, and surgical history. They do say that those who have not undergone the top surgery, they recommend following the same screening protocols as for cisgender women, regardless of use of hormone therapy, because they do have the breast tissue. If they have undergone top surgery, there's no reliable evidence for screening, so they don't recommend mammography screening. They only recommend annual clinical and physical exams. And again, the diagnostic evaluation is similar for all groups. So in summary, the male to female transgender patients are felt to be at increased risk due to the prolonged exposure to the feminizing hormones and the androgen suppression. Female to male transgender patients who do not undergo mastectomy remain at increased risk, again, because of their genotype is female. There is current data, however, that does not support that there is a defined increase incident. But despite the lacking evidence, there are currently published screening recommendations by the three societies we talked about: the Center of Excellence for Transgender Health at the University of California in San Francisco, Fenway Health in Massachusetts, and as well as the Endocrine Society. Current guidelines, again, summary is that screening mammogram every 2 years starting at the age of 50 in the transgender population who have been exposed to exogenous hormones for 5 years or longer. Providers should also discuss the risks of excessive screening and assess individuals for individual risk factors. And just to put it another way, instead of all the words, I did provide a chart, and I know you guys will have access to the slides, so it's just a helpful reminder of the current screening guidelines that are out there right now for the transgender population. So I have two more cases. This, again, these are recent cases of a 43-year-old gender male patient on testosterone for 3 years and planning to undergo gender-affirming surgery. And it's just to show you what their breasts look like. Again, still a female, and showing female breast tissue with the dense breast tissue mammographically. And again, an ultrasound is done as well, just to and showing the dense breast tissue. This is my last case, which is I find a very interesting case as well. It's a 50-year-old transgender male who's on testosterone, had a reduction mammoplasty in 2003 and a mastectomy in 2008, has a prior surgical history for excision of a papillary lesion with atypia in 2015. Mother was diagnosed with breast cancer in her 30s, maternal grandmother in her 60s. I don't remember why the patient underwent an MRI. It could have been because they had a history of atypia. But on the MRI examination, most recently, this is the left side, this is the right side. There was an enhancing mass in the subareolar region on the left, and there was also a small lesion found on the right. It was recommended for MRI-guided biopsy, and that was attempted, but because this patient has so little breast tissue, it wasn't amenable to an MRI-guided breast tissue because we weren't able to get enough tissue into the magnet to be able to access the area. So an ultrasound was done. Nothing was found at that time, so they could not find any corresponding lesion on ultrasound, and subsequently a follow-up MRI was recommended. In the meantime, the patient had a screening mammogram as well, most recently, and on the screening mammogram, this is the mammogram here, this is the left side, this is the right side. There is a small little area that was questioned behind the nipple, and so an ultrasound was done, and this is the nipple here. This was the small mass that was found. This was biopsied and shown to represent invasive ductal carcinoma. This is just a post-biopsy mammogram to show that there is a biopsy clip here, which corresponds with the initial questioned area here, and then the biopsy clip, which will be somewhere up in this tissue here. And these are typical, this is the patient, again, to refresh your memory, who had a mastectomy. So even though they had a mastectomy, I'm going to postulate that maybe they had nipple sparing, and that has caused their possible propensity of having breast cancer. And again, shown to biopsy-proven cancer on the left. The right side was checked to see if we could identify that small lesion that was identified on the right. It was not seen. However, it has been recommended to remove both the area of cancer on the left as well as the areas questioned on the MRI on the right, just to make sure, because it is concerning that it was a new development from the previous exam. So we can see that transgender patients, even with their breast removal, can have developed breast cancer. So things to consider as we come to the conclusion, just that transgender individuals face many barriers in healthcare. There is a lot of stigmatization and discrimination and abuse in the healthcare setting. There was a survey done, they surveyed 7,000 self-identified transgender patients, and it was reported, they reported 28% reported harassment in the medical setting. 28% reported high levels of postponing medical care due to their previous experienced discrimination, their inability to pay, and also lack of provider knowledge. Things that we need to consider for this population is to have increased practice and provider awareness to embrace the patient diversity. Things that we can do in the office are to provide more education in regards to transgender population to your staff. installing gender-neutral bathroom signs, and reconfiguring dressing rooms to private dressing rooms, and changing the color of hospital gowns that are more gender-neutral. So, in conclusion, I wanted to talk a little bit about genetic screening. And due to the increased accessibility and coverage of genetic screening that's out there, men are being identified, more men are being identified as carriers who can be screened before presenting with breast cancer. We know from the information I provided that survival is poor on the whole for men, and that there is that persistent disparity between male and female breast cancer due to the delayed diagnosis and less tailored therapy for men. With that greatest survival disparity seen between stage 1 and stage 2, again, median survivals of 6.1 years for men versus 14.6, it really emphasizes the need for the early diagnosis in men. The screening guidelines is just a summary. Again, the NCCN guidelines do not recommend mammography, and then just the annual clinical exam as we discussed, and prostate screening, and the ASCO guidelines. We won't go through those again, but again, those are more for all for people who carry the germline mutations. So things to consider, again, cancer-specific mortality is especially high in men younger than the age of 50. We've shown that mammography and sonography perform very well in men in the diagnostic setting. It's got very high sensitivity and specificity, approaching nearly 100%. So selective mammographic screening in these men is warranted, and I think as an uncommon disease, we may have to try an uncommon approach. And although everybody likes evidence-based practice medicine, because it's so rare, I think a lot of times in these rare instances, you may have to practice-based evidence, and then get your information from there, and then have further supporting evidence once more data is concluded, and that I think men would benefit from targeted screening to improve earlier diagnosis and improve survival. So although mammography right now is not necessarily recommended, I think with the access to genetic screening and testing, if we do identify men with a BRCA gene, I think we should start considering adjusting those guidelines and start screening these men. My personal opinion, I would suggest that we start screening them if they're carriers starting at the age of 40 mammographically, because again, we want to try to detect the cancer early before the patients are symptomatic, and when these cancers are small, to increase their survival. So that concludes my talk. I hope it was at least a little bit interesting, and that you've taken away some information, new information that you didn't have before. It's my pleasure, and if you have any questions, I'm sure we will answer them. Just email them, and we will be happy to answer them the best we can. Thank you.
Next up is Laura Fisher, who is the director of our genetics program here.
Great. Well, I'm really excited to be talking today about using artificial intelligence for breast and genetic risk assessment. And I don't have any disclosures. So today, my plan is to just review for some of you the current genetic counseling and testing service at Windsong. For those of you who aren't familiar, for those of you who have listened to some of my lectures before, this might be a little bit of a review. But then I'll dive into what we're currently doing when it comes to genetic and breast cancer risk assessment, and then talk about the future and how we're planning to use artificial intelligence to reach more patients, gain efficiencies, and more. So we'll start off by reviewing the current process here at Windsong. And so I do see patients with a personal and or family history of cancer. So we do sometimes get questions from referring providers if we see other types of genetic conditions, whether it be a prenatal consult or maybe for Ehlers-Danlos, but unfortunately we're not offering any services like that right now. It is specific to cancer genetics here at Windsong. We do offer appointments Monday through Friday, and we do offer video consults. So some of the benefits of COVID have been that we learned to offer remote visits very quickly. And beginning in October, I will be fully off-site, but patients will still have the option to come into our site where they could have the consult seeing me on a computer screen, and we can collect either the blood or the saliva sample there. Or the patient can be fully remote. We can send a saliva kit home to them to complete the genetic testing, or we can even schedule a mobile phlebotomy appointment. So we hope that'll be really convenient for patients and continue to keep everyone safe. And just a reminder, the results do take about 2 to 3 weeks, so for anyone who's referring patients that may have some surgical implication, just keep in mind that as much as sometimes the testing can come back closer to 10 days, can't really guarantee anything faster than 3 weeks. So remember, we are looking for just a pretty small portion of people. Out of all of the breast cancer that happens, we know that only about 5 to 10% of it is hereditary. And there are so many more genes now than just BRCA1 and 2. So as you can see, while BRCA1 and 2 are the most common, there's a variety of additional genes that make up a good portion of that hereditary piece of the pie. And we're always discovering new genes. So I think a lot of you have seen that probably over the past 5+ years. Once gene panel testing came available, we started to find all of these new mutations, and I would say that is, a really difficult conversation to have with women to say, listen, I know you had your BRCA1 and 2 testing done maybe 10 years ago and it was negative and we didn't think this was hereditary in your family, but now we're going back and we're retesting those women and finding that mutations were missed the first time around. Obviously, we hope it's helpful in the end, but I think for some women it can be upsetting or frustrating to learn that they and their families aren't off the hook, so to speak. These genes do run through families in an autosomal dominant pattern, meaning that both males and females are equally as likely to inherit these gene mutations, and of course the dominant part meaning that it only takes one single gene mutation to put the patient at increased risk of cancer. So I think most importantly is figuring out who needs genetic counseling and testing. We know that it's certainly not everyone, and so to narrow down that pool, we're specifically looking for people with early onset cancer, so typically diagnosed at age 45, 50 or under. We're also looking for patients with more than one primary cancer or bilateral breast cancer. Anyone with a rare cancer. So as Dr. Chen was mentioning, male breast cancer is certainly rare, and every man with breast cancer qualifies for genetic testing, and really anyone with a close blood relative with male breast cancer also qualifies for genetic testing if that male is either unwilling to do the genetic testing or has passed away. Ovarian cancer is also rare and always an indication for genetic testing. We're also looking for multiple relatives with the same or related cancers. So we often think about breast and ovarian, but we can also think about similar cancers like breast and pancreatic, colon and uterine. So there are these clusterings of cancers that go with certain genes that we would be looking for. Again, I know just to drive the point home, as Dr. Chen mentioned, these mutations are more common in people of Ashkenazi Jewish ancestry. So the rough figures that I usually use with patients is that if someone is 100% Ashkenazi Jewish, their risk of having one of these mutations is roughly 1 in 40 as compared to the general population where the risk is 1 in 400. Now I say 100% Ashkenazi Jewish because as time has gone on and direct-to-consumer testing, ancestry testing has become common, a lot of people will come in and tell me they're 3% Ashkenazi Jewish, and in general that's not going to be a statistically significant increase in their risk of having one of these mutations, but certainly I take it into account when perhaps at least one grandparent was of Ashkenazi Jewish descent. And of course, anyone where we know there's a gene mutation in the family would warrant genetic counseling and testing. I think it's also important to point out when we're talking about family, who do we really mean? So of course we're thinking about parents, siblings, children, aunts, uncles, and cousins, but when it comes to qualifying for genetic testing using insurance company criteria, we're also looking at third-degree relatives like great-grandparents and even great-aunts and uncles. So I think this is a nice way of visualizing those close blood relatives. Now, a lot of people are interested in genetic counseling and testing, but then of course the next question I get is regarding insurance coverage. Is this something that would be approved? And so my typical answers to that is that the genetic counseling appointment the cost would be similar to the visit with any other specialist. And when it comes to the testing, if you meet those criteria that we discussed a few slides before, it's oftentimes a $0 preventative service. When it's not covered as a preventative service, we often see it costing patients $100 or less. There are going to be some exceptions, of course, to every rule. So there's some insurance plans locally that I've seen where the employer chooses to exclude all genetic testing from the plan, which is unfortunate. But I think really the good news is that if patients are looking to pay out of pocket for genetic testing, either their employer, their health plan does not cover it, which again is rare, or they maybe don't meet criteria and they're still interested anyway, they're able to pay a $250 out of pocket cost. So for those of you who had heard about this testing 5+ years ago, it used to be $4,000 and you got results on 2 genes. Now we're talking about just a couple $100, and you can get quite a variety of genes. I think that, insurance coverage also is a little bit hit or miss when it comes to update testing. So for those patients who have had BRCA 1 and 2 testing done before, sometimes it's difficult to get coverage, but the $250 is sometimes a route that people are willing to take. Because sometimes we just run into these issues where perhaps an insurance company says they'll only cover genetic testing once in a patient's lifetime, which again, it's changing, but unfortunately that's still sometimes the policy with insurance companies. So if you're interested in referring patients for genetic counseling and testing, there's a variety of ways to do it, but one way would be to complete this form. We created this so that you even have a little checklist right there of all of the criteria that we would be looking for, just to see when you're putting that patient's name on there, sending them over, what the reason you're sending them for is, and also to make sure we've got a high likelihood that they are going to be approved for testing. So during the counseling process, what I do before we test a patient is of course collect their medical history in a 3-generation pedigree, evaluate their cancer risks by using 4 different risk models, which we'll talk a little bit more about later. The benefit of the software I currently use is that we can also calculate the risk of a gene mutation. So I think that's a pretty powerful tool when having a discussion with patients. A lot of patients come to me pretty anxious, concerned about their family history, but oftentimes if we can calculate that risk and show them, as much as you thought there was a high likelihood the cancer in your family was hereditary, your risk of a BRCA 1 or 2 mutation is about 5%. And I think that goes a long way in helping patients have a lower level of anxiety as they wait for their genetic test results. I discuss with all of my patients the inheritance pattern of these genes, the penetrance, meaning the different levels of risk for different cancer types, and the variable expressivity. So I think that's especially important for patients where maybe they only have a family history of breast cancer, but I have to warn them that this gene could present itself with either breast or ovarian cancer. So as much as a patient may not be coming into the appointment looking to learn about the ovarian cancer risk, we always want to explain that that's a possible outcome. And I think a really important piece of this for me is making sure the patients know exactly what they're getting into. So during the informed consent, I'm primarily summarizing what we've gone over during the duration of the appointment, but I also always be sure to include a piece on genetic discrimination, which we'll touch on in a minute. Go over all of the benefits and limitations of testing with patients, make sure they know that this test is not diagnosing them with a cancer, but rather giving them information about their risk to develop cancer in the future. Really making sure they're mentally and emotionally prepared. I think that a lot of the providers in the community are now doing a really great job with identifying women at a young age who have a family history of cancer. I've seen sort of an influx lately of maybe 19-year-old, 22-year-old patients, which is great, and we have really meaningful conversations, but sometimes those patients I think wisely recognize they may not be ready for such heavy information, but at least having the knowledge, knowing when, that I'm here when they're ready to come back and do the testing, I think is really important. Of course, talking about the benefits to family members, how we might see coverage when someone has a mutation for any preventative screenings or surgeries. But then also, recognizing that for some patients, the limitations are significant and would outweigh the benefits, either feeling maybe anxious or depressed because of the information, worrying about the concerns of genetic discrimination, and also recognizing that just because their results come back normal doesn't mean they can go about skipping any screenings or even necessarily having a reduced cancer risk. A common question that I get from patients is about direct-to-consumer testing, so I'll touch on that. We do know that direct-to-consumer testing is available in a couple of formats. One of those is as ancestry testing only, but the other includes not only ancestry, but also health information. It's important to recognize that this does vary by company. So, for example, 23andMe, they do analyze the BRCA1 and 2 genes, but they only report out on the 3 common Ashkenazi Jewish mutations, or what we call the founder mutations. And it's important to make sure patients realize that there's actually more than 1,000 different mutations in these 2 genes combined, so it's a pretty small portion of people with these mutations that we're going to detect. 23andMe has also started to look for a couple of polyposis gene mutations, and even Ancestry.com has recently gotten into this game of health traits. I think, from a competitive standpoint, they had to offer something to continue to appeal to those patients instead of everyone who's interested in health traits going to 23andMe. And so they are looking for a greater portion of mutations. So they're identifying 80% of known BRCA1 and 2 mutations, as well as 80% of mutations that cause Lynch syndrome. Again, biggest thing here is making sure patients know what they're getting themselves into, knowing the limitations that this test can't detect all mutations, but any mutations that are detected should be confirmed in a clinical grade laboratory before using them to make any medical management decisions. So after the genetic testing is complete, of course, I review with patients their results, the significance of those results, and then the recommendations for medical management, implications for family members, and any available resources. So there's a lot of great national as well as local organizations for patients to either get support or information, because once I meet with them after the testing, I usually turn them back to their referring providers, and we don't typically have an ongoing sort of relationship or meeting. One question that I do get a lot, so I thought I would touch on, is the different types of results. Focusing on that middle column there to start, recognizing that there are actually 3 different types of results that we could receive when we do genetic testing. Of course, those being positive, negative, and a VUS, or what we call a variant of unknown significance. But I think the most important thing to recognize is that we do treat variants of unknown significance the same way that we would treat a negative result, meaning we would not advise changes to a patient's medical management because we truly do not know what it means. In fact, in 80 to 90% of cases, studies have shown that these variants ultimately get reclassified to benign. So it's certainly in a patient's favor that this will not be something significant. I often try to really downplay these with patients. There's no sense in them being anxious about this for potentially years while we wait for the research to catch up and figure out the true significance. So I think it's important for patients to recognize they're there, understand they'll get an update from me in the future, but odds would suggest that their variant would get reclassified to benign. So before I get off my soapbox, I'd just like to always say again that a variant should not be used in clinical decision making, and again, that's because most of these get reclassified to benign, and also because that's what our guidelines suggest. As promised, to touch on genetic discrimination, we know that there was the Genetic Information Non-Discrimination Act, or GINA, that was signed into effect in 2008. That prohibits discrimination from employers and most health insurance companies. But it is important for patients to recognize this does not protect things like their life insurance, long-term care insurance, or disability insurance. I think we can be strategic with how patients go about this in terms of the timing of when they obtain these policies, but also sort of weighing that with the benefits of the testing and what's the priority for the patient. Of course, there's exceptions, so sometimes with smaller employers, this law may not be applicable. So hopefully that gives you a good sense of what I'm doing right now if you've either never referred patients for genetic counseling or testing or have only done it on a limited basis. But I'm always happy to answer any questions, and my contact information will be on the last slide. But with that, I'd like to go over what we're currently doing when it comes to genetic and breast cancer risk assessment here at Windsong. So at Windsong, we really wanted to start identifying patients who were at an elevated risk of breast cancer, or those patients who could benefit from genetic counseling and testing. So what we piloted was when patients were coming in for their mammography appointment, they were being handed a tablet and asked to complete some questions about their medical and family history. The goal was to obtain their lifetime risk of breast cancer using the Tyrer-Cuzick risk model, which some studies have shown to likely be the most accurate risk model, and it does take the most factors into account. We wanted this to be used by the radiologists, and some of you may have seen that risk number printed on the mammography report. But ultimately, it was a challenge in terms of the logistics. So this is patients completing it at their mammography appointment. When they're here, we've got a pretty efficient process to move people along, and so sometimes it was creating a delay. It also wasn't ideal because the patients were, again, at an appointment and trying to answer questions about their family history that they may have actually benefited from reaching out to their relatives to say, you know, hey, did you have cancer? How old were you when you were diagnosed? Because those are factors that matter. So ultimately, this method was not efficient, and we stopped implementing it, understanding that we've got something better in the pipeline, which I'll get to soon. And in terms of what was happening at a genetic counseling appointment is I was calculating 4 different risk models. So that was the Gale model, CLOS, BRCA Pro, and Tyrer-Cuzick. I had software that could calculate those all at one time. I review it live with the patients. I still do. And I think it gives them a nice sense of their range of risk. None of these models is perfect, explaining the benefits and limitations of the models, giving them a sense, though, of where they stand to say if they may benefit from breast MRIs, of course, with that threshold being 20%. So if you are referring patients, you will see that in the discussion section of my note. I'll state what their range of risk is, along with some information on whether or not they would qualify for breast MRIs based on that threshold. So that's really what's happening right now. The risk factors that are being included, again, like I mentioned, how old were they themselves or their relatives when they were diagnosed with a cancer? Are there rare cancers? What have their previous breast biopsies shown? How many have they had? So there's a lot of information that needs to be collected. I do this with all of my patients at each appointment. Is that the most efficient? I think most would argue probably not, which we have moved towards patients completing a questionnaire before their genetic counseling appointment. But for those of you who are trying to do this on your own, it's pretty cumbersome. So this is just a quick picture of the Gale model that you can find online, right? You've got to read through a number of questions, get the patient's information. More than likely, you're flipping between screens or notes in your EMR to gather all of this information. I think even more complicated or overwhelming to look at is the Tyrer-Cuzick model and think about plugging in all of those factors. And that's really where artificial intelligence comes in. So in terms of just starting off with some definitions, we know that AI refers to the simulation of human intelligence in machines that are programmed to think like humans and mimic their actions. The term may also be applied to any machine that exhibits traits associated with a human mind, such as learning and problem solving. But this is really, of course, in healthcare best used as a clinical decision tool to aid really rather than replace any human decision making. But technology is increasingly shaping the practice of genetic counseling, and I think AI is no exception, where the biggest, I think, piece for genetic counseling is going to be chatbots. So chatbots are just one of the many AI applications. There's a lot of other applications like search engine algorithms, digital personal assistants, and facial recognition. But a chatbot, as many of you may know, is really just a technology-based simulated conversation tool that allows us to scale communications. What we really want to do is leverage AI to answer these simple questions. How old were you when you had your first menstrual period? How many live-born children have you had, etc. We can increase and maintain consumer engagement and provide convenient, easy access between consumers and service providers. Of course, there's a history of using chatbots in a number of different industries between banking, insurance, retail, and more. But in terms of healthcare, chatbots have been used already to do things like collect and triage non-emergency symptoms, facilitate behavior change among patients with obesity and diabetes, deliver cognitive behavioral therapy for patients with mental health issues. So a variety of settings have been used already. But they're pretty accessible. In most cases, you can either download a chatbot through an app or even click right through a hyperlink. And studies have shown that about 77% of US adults report owning a smartphone. One funny comment that I had received from a colleague when I was reviewing this presentation was, it's possible that maybe more than 77% of adults actually have a smartphone. Some people don't realize that more than just Apple makes smartphones. So sometimes you forget what you don't know, and they are sort of everywhere. And so chatbots have already been used in genetics. So one example of a chatbot that's been designed for genetics is through a company called Clear Genetics, and their chatbot has interacted with more than 67,000 patients. What they have gathered is that 80% of patients who were invited to engage did choose to do so, so I think that's a pretty high uptake rate. With a 92% overall satisfaction rate. So this is something that patients are overall really pleased with. There was a study that was done on 62 participants who were engaging in a genomics research protocol. And the participants overwhelmingly supported the use of chatbots. This was done with qualitative research. They liked it to use as a consent for the research, a mechanism to interact with their healthcare providers, and even follow up after they received their results. The participants thought it was actually more informative than previous in-person paper-based consent experience, which really allowed them to customize the length of their chat, the ability to type in questions. So right now, of course, I think as most of us do, we have a standard protocol that we go through with patients during an appointment, and sometimes patients are more or less engaged, and I think using a chatbot allows patients to go through at their own pace instead of essentially at the pace that we dictate. So to give you a visual of what a chatbot might look like, you can see here, again, smartphone compatible, little blurbs from the chatbot asking questions, drop-down boxes with, easy to select options, even some visuals like a little family tree, so really quite user-friendly. Of course, the benefits of artificial intelligence are going to be able to grow the reach and speed of care delivery. So I think for primary care providers, this is a really important point because the US PSTF came out with guidelines last year stating that primary care physicians should be screening women with a personal or family history of breast, ovarian, peritoneal, tubal cancer, or women of Ashkenazi Jewish ancestry to see if they would be good candidates for genetic counseling and testing, and then referring those patients if they do meet criteria. So hopefully these chatbots will allow, again, whether it's at Windsong or in your own practice, for us to catch more of these women who are probably currently slipping through the cracks. Of course, we want to be able to augment a clinician's strengths, so free up time for the unique activities that do actually require a human, whether that's psychosocial assessment or support, or perhaps missing data points, gathering those. And then, of course, there's a lot of time that would hopefully be created by these AI-related efficiencies that could fuel patient-centered care, which is, I think, what we're all striving for. Some limitations, although I think that these can be avoided when AI is implemented appropriately is the fact that it does require large data sets. So with some genetic conditions, we are talking rare diseases and therefore may not be relevant. Whether it's the black box nature of AI, where you don't necessarily know why a certain outcome happened because there's not visibility in how those results are determined. AI, of course, not being human, may have a little bit more difficulty with abstract concepts. A bit of inflexibility, not being able to change the rules, the context, and the fear that there might be some correlation drawn and risk equating that with causation, essentially. Again, I think in the setting, that you're implementing AI, it's just important to make sure that these limitations can be overcome or addressed. So I think what AI is going to do is really shift the genetic counseling skill set. So there's a lot of things that I do right now that I think could be done really well by a chatbot, but would allow me to use my skill set in a different way. So I think one example is information gathering. So right now I spend a lot of time with patients, again, asking them basic questions like, age at menarche, age at menopause, live-born children, etc., where instead I can use that time to assess a patient's values and beliefs. So it would be a shift, nonetheless. Currently, when I'm gathering that family history, asking, how many aunts had breast cancer, how old when they were diagnosed, through those conversations, a lot of valuable stories come up, whether it's, oh yeah, every woman in my family gets breast cancer, so I know I'm doomed. And addressing that, right? Making sure patients know that, okay, your risk of having a gene mutation may be elevated, but it's not the 100% risk that you think it is because of how it's just so happened to fall in your family. So spending more time, maybe gathering those stories that could be missed if I'm not taking a family history in a traditional way. In terms of giving information, I'd have more time to answer questions about how the standardized information applies to patients' unique circumstances. So oftentimes when I'm going over, what would happen if we found that you had a gene mutation, well, we would recommend mammograms and MRIs staggered every 6 months. And some women are claustrophobic or, may have a health condition that would make MRIs contraindicated. But it's hard to spend the time on that when I'm just trying to get out the basics. So it would certainly be nice if all of that information was gathered by a chatbot to allow me to spend my time really giving that personalized care. And then, of course, there's a lot of coordination, logistics, but if the chatbot's doing the bulk of the work, then any intervention that I have to take could be done in a patient-friendly and individualized way. So in terms of how we're planning to use AI here at Windsong, we are going to be implementing what's called the Ambry Care Program with a goal implementation date of the spring of 2021. We were hoping to do this sooner, but I think as almost everything in life, COVID has set the plans back a little bit. So the CARE program really just stands for a comprehensive assessment, risk, and education. And so what this is going to look like is a HIPAA-compliant clinical chatbot that's going to facilitate virtual conversations with patients. They'll be able to do this on their smartphone, tablet, laptop, or even a desktop. But I think the big piece is smartphone compatible because what we were doing before was having patients fill it out on a tablet in our office. Again, it was on sort of our time and not the patient's time, didn't give the patient any time to do research or check with family members, and it's not smartphone compatible, which was a challenge. The chatbot will be able to take their medical, their family history, and even the option of providing them with educational videos. What we'll get from all of that information coming into the chatbot is a patient's Tyrer-Cuzick lifetime breast cancer risk to be used by the radiologist when the patients come in for the mammograms. So the idea is that the patients would get this before their appointment and complete it at home. We will have the option for those patients who don't have technology accessible. We will have the option for them to complete it here on site, but I think the big piece would be moving the bulk of it to the patient's own time and off site. But these chatbots will also be able to identify candidates for genetic counseling and testing. So I think this will be big, like I said, to address that guideline issued by the USPSTF. Because if we can do this in an efficient way, we can make sure that more women are being detected and referred appropriately. The workflow that we're planning is for patients to receive a text message before their annual mammography appointment with an invitation to participate. Patients are able to opt out, and again, they can complete it on site if needed. If they're a candidate for genetic testing, they will have the option to learn more via educational visuals and videos. So the chatbot can ask them if they want to learn more, ask them what questions they have about inheritance, cancers associated, etc. And then we're even going to allow patients to consider genetic testing at the time of their mammography appointment, with a lot of these fine details still to be worked out. We're absolutely interested, though, in any input you may have, so please feel free to reach out to us. We want to make sure the implementation is as smooth as possible. Obviously, happy to adjust as we go along, but again, if you have input, more than happy to listen in on that now. And then post-test genetic counseling will be available for all patients. So like we said, what chatbots are going to do really well is take in some of that standard information. And I think my time is best spent going over the results with patients. Often I meet with a patient, we've talked for maybe 45 minutes, and at the end I'll ask them, what questions may remain. And often they say, well, I think I'm going to have all the questions when I get the results back. And that really leads me to believe that the time would be best spent after the test results are in versus ahead of time. They would only be referred or identified as a candidate for genetic testing if they meet those NCCN criteria, which are those young cancers, rare cancers, multiple family members with the same or related cancers, or Jewish ancestry, those types of criteria. To give you a visual of what the workflow is going to look like, again, we're trying to capture more women who are at elevated risk of breast cancer, could benefit from genetic counseling and testing really in this efficient way, where the risk assessment is going to happen. At the beginning, they'll be offered this pre-test genetics education with the option for on-site genetic testing. And if they're not comfortable proceeding with genetic testing, of course, the option to do pre-test counseling as well. But then to all patients, whether their results are positive, negative, or inconclusive, offering them post-test genetics education and counseling, and then sending them back to the referring providers with those medical management recommendations. So we hope that this is going to be a really efficient way, something that'll be painless for patients, seamless for us to integrate the information, and really better quality of care. So in summary, if you're wondering who may benefit from genetic counseling and testing at Windsong, it's going to be those patients with a personal or family history of young, multiple, or rare cancers. I go over with patients all the benefits and limitations, review results, medical management implications for themselves and their family, and we hope that we're going to be able to continue to offer this service, but in an even more efficient way as we implement AI to really reach more patients and improve the experience for both the patients and free up clinician time to focus on our strengths. So I greatly appreciate your time today. I'm happy to answer any questions as they come up, and enjoy the rest of your weekend. Thank you so much.
So next up is Dr. Herbert DeVivier, an oncologist with Great Lakes Cancer Care, who will be presenting on liquid biopsy.
Well, good morning, or nearly good afternoon. You've had a long road. You've discussed multiple different topics, including PET and MRIs, interventional radiology, CMS advancements, male cancer, and now most recently genetics. And I think we're going to end the day with just a little bit of learning about genomics and how it relates to genetics, both germline and somatic testing, and how that is then related to liquid biopsy and lung cancer. I'm Dr. Herbert DeVivier, and I'm a staff physician at Great Lakes Cancer Care, and I'd like to thank Windsong for allowing me to give you this brief discussion. and we will move forward. So learning objectives for today will be to understand the difference between germline and somatic genetic testing, learn how non-small cell lung carcinoma is staged and the staging influences treatment decisions, and learn how somatic testing improves treatment planning in non-small cell lung cancer. This is just our outline. We'll talk about genetic testing first, then non-small cell lung cancer, then liquid biopsy, what biomarkers are and why they're important, and then treatment decision making. Within a gene, there are exons, which multiple exons equal an exome, and these are all the genes that are located in our book. However, they only make up 1% of the DNA code, so 99% of the coding sequences we have an unclear. In exome sequencing, we're looking for typographic abnormalities within each word of the genetic sequencing. So to do exomic analysis takes some amount of time because you're looking at each letter of each word within all the exons, which are all the genes within our genome. In germline genetic testing, you're looking for genetic changes which an individual has inherited. So those are the changes such as BRCA1, BRCA2, PALB2, etc. And those are the changes which Laura, who was right before me, was discussing. The history of genetic testing in the germline arena started in the 1800s, and then by 1925 the genetic theory was accepted. In 1950, Watson and Crick discovered the double helix structure of DNA. 1960 about, the additional copy of chromosome 21 was linked to Down syndrome. And then in 1970, Dr. Sanger discovered that rapid sequencing techniques which were used for RNA could also be used to sequence DNA. In 1990, the Genome Project began, and in 1999, less than 10 years later, the first human genome project was completed. And in the mid-90s, Myriad introduced its first molecular test for hereditary breast and ovarian cancer. Now there are at least 13 additional companies offering genetic testing for hereditary cancers. So again, germline genetic testing is looking for those genetic changes which an individual has inherited. Somatic testing, on the other hand, is looking for genetic changes which are acquired after you're born. They're, for our purposes, looking at the genes of the tumor, not necessarily of the individual. So, as an example, if a tumor is BRCA1 driven, that tumor will have BRCA1 in it. That's the germline. But it will also have other acquired genetic abnormalities which in part drive the oncogenesis of that tumor. So in somatic testing, we're not as interested in the BRCA gene as we are in the acquired genetic abnormalities which are driving the oncogenic process. Methods for testing of somatic changes are by PCR, which make numerous copies of short DNA sections from very small samples and are amplifying the DNA. DNA sequencing, such as Sanger, with the older method, which looks at single genes, only a few genes at a time. It's very reliable, but can only read a short section of DNA from one patient at a time. And now more recently, we have the next generation sequencing, which can sequence millions of small DNA fragments among many different patients in parallel. Much faster results are obtained using next generation sequencing compared to Sanger sequencing. So we're going to turn to lung cancer. I want you to kind of put that definition of somatic versus germline in the back of your head for now. We'll come back to it later on. But we're going to talk about lung cancer at this point. There are non-small cell lung cancer, which makes up approximately 75% of all lung cancers, and small cell lung cancer, which makes up approximately 25%. There are subtypes to non-small cell lung cancer, including adenocarcinoma and squamous cell, as well as adenosquamous, large cell. But in general, they're all treated the same way, and they're all considered non-small cell lung cancer. The lifetime risk of developing lung cancer is approximately 6%. This is compared to the lifetime risk of developing breast cancer of approximately 13%, and the lifetime risk of prostate cancer of approximately 11%. The lifetime risk of colon cancer is approximately 4%. So you can see that in terms of lifetime risks, both breast and prostate occur much more frequently than lung cancer. However, despite that, there are 228,000 new cases that are going to be diagnosed in 2020, and it represents about 13% of all cancers. There's going to be 136,000 deaths this year related to non-small cell lung carcinoma. And the 5-year relative survival rate across all stages is only approximately 20%. And the 5-year relative survival by tumor burden decreases as the burden increases. So for a localized disease, 5-year survivals are approximately 60%, whereas for regional disease, 22%, and for distant disease, only 6%. It is the second most common cancer behind breast cancer and ahead of prostate cancer, despite the fact that the incidence is only, the lifetime incidence is only 6%. 98% of lung cancers occur between the ages of 45 and 84. 83% of the cases occurring between the ages of 55 and 84. 10% of the cases occur in patients greater than 84, and 36 or a third of the cases between in patients greater than 75 years old. So this is a relatively elderly population that we are confronted with in regards to treatment of non-small cell lung cancer, especially those with advanced disease, and therefore it would behoove us to be able to treat these patients with regimens that are relatively non-toxic but with good efficacy. The staging system is relatively complicated, and that is just to show you that there are many different definitions for the different T or tumor staging, as well as for the regional lymph nodes. Please pay attention though to the metastasis, and you'll note that under M1 that there are 3 different sections that can lead to M1 disease. M1A, where there are separate tumor nodules in the contralateral lobe, so the lobe opposite the primary, with either pleural or pericardial nodules or malignant or pericardial effusion. So a malignant effusion would be considered M1A. M1B, which is a single extrathoracic metastasis in a single organ, so a single solitary metastasis to the liver would be considered M1B, and then anything greater than that would be considered M1C, so multiple extrathoracic metastases to one or several organs. Regardless of which M1 you happen to have, you will be stage either 4A or 4B. There is no significant survival difference between those two. And this is where we're going to concentrate today's discussion, is in the treatment of these advanced non-small cell lung cancer patients. Please note, though, that a lot of what I'm about to say is being translated into earlier stages of treatment. So there are treatments now utilizing immuno-oncology medications for stage 3C and 3B. There are studies which are ongoing, which are looking at earlier stages and adjuvant therapy utilizing immuno-oncology medications to improve survival. The other lung cancer that we're going to briefly touch on right now is small cell. It accounts for approximately 15 to 25% of all lung cancer patients, or approximately 35,000 new cases in 2020. The cell of origin for small cell is an epithelial cell, and 90% of these small cell lung cancers will express the immunohistochemical stain TTF1 or thyroid transcription factor. The cancer itself is usually centrally located, and median survival, if untreated, is approximately 4 months. The staging system for small cell combines an older staging system, which was either local or extensive, with the TNM staging system. And so we have local disease being early stage disease, so any disease less than 7 centimeters and located greater than 2 centimeters distal to the carina is disease which usually can be incorporated into a single reasonable radiation field, and treatment could include surgery, SABR, or chemotherapy. Prophylactic cranial radiation has been shown to improve overall survival in this group of patients with relatively localized disease. Alternatively, if the patient has more advanced disease, which would be considered extensive, that is, anything greater than 7 centimeters, or any size that has direct invasion into the parietal pleura or pericardium, or is less than 2 centimeters distal to the carina, or has separate tumor nodules in the ipsilateral lung or invasion of other structures, this is not something that can be encompassed in a reasonable radiation field, and so is considered extensive. And any disease which is located distant, so metastatic disease, such as contralateral lobe tumors with nodules or malignant effusions or distant metastases, is considered advanced stage. For those advanced stage patients, there are some treatment options, including combined immuno-oncology agents as well as combined immuno-oncology and chemotherapy agents, but overall the survival for these patients is relatively poor at this particular time. First line, chemotherapy plus an IO drug called atezolizumab, followed by maintenance therapy, or chemotherapy plus durvalumab followed by maintenance therapy, has been shown to be beneficial in these extensive stage patients, improving progression-free survival with some small but not yet significant improvements in overall survival. For recurrent and progressive disease, we have other drugs such as pembrolizumab when PD-L1 positive, and lubrenectedin, which is in orphan drug status but has a high response rate. This is just a cartoon showing that there are multiple different targets which are being addressed as potential therapeutic targets in extensive stage small cell lung carcinoma. So there's ongoing efforts to improve that patient population's overall survival as it lags behind non-small cell lung cancer. Liquid biopsy is what you're here to learn about. And liquid biopsy began approximately 150 years ago when T.R. Ashworth first described the presence of epithelial cells in the blood of a woman with metastatic breast carcinoma that were similar in appearance to her primary tumor cells. So 150 years ago was the first example of the discovery of circulating tumor cell, CTC. And since that time, there's been a variety of solid tumors that we have found circulating tumor cells in, including breast cancer as well as lung cancer. They represent, though, a rare population of cells, usually less than 10 cells per milliliter of blood compared to 1 million white blood cells per milliliter of blood. So a relatively small population. However, the detection of CTCs within a routine blood specimen provides an opportunity to monitor cancer non-invasively and, in essence, is a liquid biopsy. Since the discovery of the CTCs, we've also found that not only does a tumor shed circulating tumor cells, whole cells, but also through apoptosis and necrosis sheds its DNA as well as its RNA and protein exosomes. The talk today will not describe any work with the RNA, which is something which is being utilized now, and will not discuss any protein exosomes, but we'll concentrate on the use of circulating tumor DNA and how that helps us with treatment of lung cancer. So it is a non-invasive blood test. It detects both circulating tumor cells and fragments of tumor DNA, RNA, and protein that are shed into the blood from the primary tumor as well as from metastatic sites. The idea is to collect and amplify the DNA, and then to sequence the DNA to look for genetic alterations, which are the genetic oncogenic drivers of the tumor. So tumor cells can shed complete circulating tumor cells, but they can also shed DNA. This is just another way of looking at it, that a tumor can shed both complete whole cells, which can be isolated and amplified in culture and then analyzed, but it can also shed DNA, which can be isolated even though there's very, very small amounts. It can then be amplified using next generation sequencing or Sanger sequencing, and then analyzed just as you would if you were looking for germline genetic testing and drew blood from a patient or used saliva from a patient. So why do we do this? The whole reason for doing this is to find genetic biomarkers that are the oncogenic drivers of the tumor. Once those are found, pharmaceutical companies have the opportunity to develop drugs that can block those drivers and therefore are a treatment. So DNA sequencing that drives or causes disease or is associated with susceptibility to disease are the biomarkers, and they're important because we are looking for opportunities to develop drugs that target these drivers. Genetic biomarkers specific to non-small cell lung carcinoma, EGFR, which occurs approximately 10 to 20% of the time, can be treated with tyrosine kinase inhibitors or TKIs with response rates of 50 to 80%. Significantly higher than what you would get if you treated the same patient with any other treatment option, including the immuno-oncology drugs that are PD-L1 blockers, such as pembrolizumab or nivolumab. Other drivers include ALK, which also can be seen in about 4 to 7% of patients, and ROS1 in about 1 to 2% of patients. These all have very specific targeted treatments. For ALK, alectinib, ceritinib, and crizotinib can all lead to 60 to 75% response rates, whereas with ROS1 you have a large list, including entrectinib, ceritinib, lorlatinib, which can also lead to 60 to 80% response rates. So what you're seeing is an oncogenic driver, EGFR, a biomarker, a specific treatment leading to a high response rate with relatively minimal side effects compared to the previous treatments that we had, which were before the advent of immuno-oncology agents, just chemotherapy alone. Remembering that non-small cell lung cancer occurs most often in the elderly, and that these are patients that have a high risk for developing significant side effects utilizing chemotherapy, the use of biomarkers allows you to treat patients with relatively non-toxic medications with high response rates. This is kind of exactly what it is we were trying to accomplish, and these biomarkers are allowing us to do that. Now, biomarkers are being found at a relatively quick rate because EGFR, ALK, and ROS are 3. There is another one that came as a kind of a set, and that was BRAF. The V600E mutation is also one of the original biomarkers. But then over the last year, we've had 3 new medications specifically targeting 3 new biomarkers. Those are the MET or MET, the RET or RET, and then the NTRK or NTRK. These are all genetic biomarkers. They're all drivers of disease, and with specific treatments, as can be seen, lead to, again, high response rates of 60 to 70%, sometimes greater. The other nice thing about being able to use a targeted therapy is that usually the responses are relatively long-lasting, meaning that these patients can hold responses for sometimes 18 to 24 or longer months before they become resistant and have to move on to another therapy. From the perspective of an oncologist, the longer we can keep somebody on, the better we're able to allow the pharmaceutical companies to determine through genomic testing the causes of the development of resistance, and then to develop drugs to kind of treat the new resistance. In summary, genetic testing consists of either germline testing, which is testing the inherited genetic abnormalities that a person may have, which increases their risk for the development of a cancer, and somatic testing, which is the testing of cell-free DNA from a tumor, looking for the acquired abnormalities which are driving the tumor. Why is it important? It's important because as we find these genetic abnormalities and further define them, we can develop treatments against those specific abnormalities, which oftentimes lead to very high response rates. So the NCCN guidelines would suggest that every patient with metastatic non-small cell lung carcinoma undergo genetic biomarker testing prior to any treatment, because in those individuals where you find the genetic biomarker, you can use a very specific, lower toxicity treatment with a higher response rate, which is kind of the goal of any treatment that you give. For those patients, obviously unfortunate enough to not have a targeted treatment, you can look for PD-L1. PD-L1 is a guide to help you determine if you should be using an immuno-oncology drug such as pembrolizumab or nivolumab, either as a monotherapy or in combination with chemotherapy. The higher the PD-L1 percentage, the more likely a patient is to respond to immuno-oncology agent as a monotherapy. So from an algorithmic point of view, an oncologist would first look for a biomarker. If the biomarker is positive, treat with the appropriate treatment. If the biomarker is negative, look to PD-L1 testing. If PD-L1 is high, you can use an immuno-oncology agent as a monotherapy. If PD-L1 is low, you use a combination of chemotherapy and an immuno-oncology agent to get the best responses. We're falling further away from utilizing chemotherapy only as we find that these medications in combination with chemo do offer increased survival and progression-free survival. There is one area in which chemotherapy only can be considered, and that's in a patient who is rapidly deteriorating, and you believe that the deterioration is due in part to rapid progression of disease, or in patients who are highly anxious about waiting for the results of these tests, which, although the turnaround time is relatively quickly, can take up to 2 weeks. I'd like to thank you for spending this time with me. I hope that my talk helped you in some way in learning a little bit more about what I do and how biomarker and liquid biopsy can help with the treatment of non-small cell lung cancer. And again, I'd like to thank Windsong for allowing me to come today to talk. I hope you guys have a great rest of your weekend. Thank you.
Thank you, Dr. DeVivier. Great presentation, fascinating science. On behalf of Windsong's conference presenters, we thank you for attending our online conference. Please don't forget to complete your post-test and conference evaluation. Questions can be sent to cme@windsongwny.com. Thank you.